Dr. Anil sir and Dr. Subramanian sir. This was followed by a short session by Dr. Shravnadipti ma'am, Associate Professor Community Medicine, on understanding the student-doctor learning concept. She highlighted that learner-doctor method, selecting achievable competencies, mapping competency to activity, to assessment, and the responsibilities and cautions for supervising physicians. Then we wrapped the morning session with a group photo session featuring teams in different color codes along with our Dean sir and respected MEE members, followed by a delicious lunch. Then post-lunch, we attended an insightful session on self-directed learning by Dr. Ramya Ramakrishna ma'am. She began with the story of Ekalavya, emphasizing the role of self-driven learning. Ma'am explained the concept of SDL-related educational theories, Cope's continuum of learning, the qualities of a self-directed learner, and Grove's model, which includes 4 stages: dependent, interested, involved, and self-directed. She also clearly described how to conduct SDL in 2 sessions, the format to be followed, the venues, digital tools, assessment and evaluation methods, and the overall benefits. And a sample SDL plan was also prepared by the medicine department, was also being demonstrated by ma'am. And the final session of the day was conducted by Dr. Shiva Chandra Raju sir, Professor, Department of Pharmacology, on writing effective essay questions and MCQs. Sir covered assessment methods, blueprinting, and essential characteristics of assessment tools such as validity, reliability, and core quality pillars. He explained the criteria for well-constructed essay questions, noting that short essays assess depth, while long essays assess breadth of learning. He also described the limitations of essays and how structured essay questions, modified essay questions, and restricted response essays can overcome these drawbacks. Sir then discussed short essay questions, their merits and demerits, and after a short tea break with healthy snacks, Sir delivered an excellent session on constructive, effective MCQs for CBME. He discussed merits, limitations, key components, terminology such as STEM, item, and distractors. Sir concluded with an overview of the next exam, types of clinical vignettes, elements of vignette, and the 10 guidelines for constructing MCQs, followed by a brief explanation of item analysis. Finally, the session concluded with the feedback from the participants. And a big thank you for all the MEU members for their efforts in making these sessions more engaging and interactive. Thank you.
1 minute. You say okay, I will give that. Okay, good morning. Good morning. Good morning. Okay. I think all of us had at some point of our time at 8 o'clock class, right? Some point in, say for example, 1 or 2 years, you would have had 8 o'clock class, right? Okay. What are the usual problems encountered during such a session? 8 o'clock class.
Punctuality will not be maintained by the student.
Okay, punctuality is not maintained. They will come leisurely. Sometimes we also come leisurely, right? Okay. Then? Huh? Who are drowsy? Students are, huh? Yes, you will be late because of daily course. That is a different thing. Okay. Okay. Keeping all the technical aspects aside, as far as core teaching is concerned, what are the problems you encounter? No, I have kept all those things aside. Lecture hall won't be ready. Okay. Then IT. There might be some glitches. IT person may not be there, or even if it is there, there will be some problem. Then student will be sleepy. That is very well taken. Very important point. 8 o'clock. It is very difficult to arouse them. Planning of the session. In what sense?
Even if it is getting late, it should start and then within that
Yes, exactly. Even though if you have come on time, students will be entering and there will be delay. IT person, we may have some problem with the LCD, okay? Then, in spite of that, some valuable 10 minutes would have gone, okay? Would have come prepared for 1 hour session. It may not be possible to complete everything, and by the time we are enthusiastic, the next person will be standing there, then we may have to get scoldings or some nice comments in the WhatsApp group, something like that, right? Okay. Second. So these are some of the things what we generally, and there might be a different set of problem if it were to be a practical session. Okay. So with this background, let us deal with this particular topic. Develop a lesson plan appropriate to objectives and teaching learning method. Okay. So, what is plan? What is plan? What do you mean by plan? How to do it in an effective way? Any given activity or any given say for example task, right? Okay. Then okay, it contains everything, not only the content, the delivery also, planning or how you are going to set the things right, and also whatever you have set it has to be executed, right? Okay. Then yes, exactly. If something goes out of the way because things are not in our control, okay, there should be plan B. Okay, there should be something backup, or you have to deal with such circumstances. Okay, then what is lesson plan? How to take the lesson. Okay, that is very, very simple words, but how to take the lesson, how to take has got lot of meaning. How to take, okay, it how to effectively manage the entire bit of this thing, say for example particular topic. Okay, so this is all about the lesson plan. Okay, so at the end of the session the participant would be able to define a lesson plan, list the advantages of having a lesson plan, list various elements of lesson plan, then of course how we are going to plan a lesson plan, then some of the important points in implementing lesson plan. Okay, you would have prepared something, but you have to stick to those lesson plan, right? It is also one big task. Okay, it should not be merely a documentation thing which is asked by NAC or IQAC department, right? Okay, then list important points in revising the lesson plan. Okay, so these objectives let us try to discuss. As we have already told, plan is nothing but a carefully arranged, considered arrangements, okay, for carrying out some future activity. Planning is always for a future activity. Okay, it may be in recent time or it may be well in advance. Sometimes if we have so many commitments, we may plan well in advance, right? So this is nothing but carefully considered arrangements for carrying out some future activity, and the success of that activity, whatever we have planned, mainly depends on how meticulously we have arranged the things, and also it depends on how effectively we execute it. Okay, then it applies, this plan applies to all educational activity. It is not only with respect to teaching the students or teaching the Indian medical graduate, but also it depends or it applies to the assessment also. Say for example, rather than teaching, lot of our quality time goes in assessment, right? So for that also we need plan, but it in a different way. It is not called as a lesson plan. Okay, So this is about plan. Then what is a lesson? All of us know it is part of subject taught or studied at one given point of time. Say for example, if it is a big topic, we may take a little bit of it, right? Okay, so it is part of the subject taught or studied at one time. Thus it is in educational jargon, it can be defined as it is the smallest unit of educational experience, smallest unit of educational experience and activities provided to the learners. Okay, then all of us are having at least quite few years of experience in teaching, right? Probably in our UG days, PG days, the junior faculties, and of course after entering as faculty members we had quite experience in teaching. Did you go according to the lesson plan, or have you already planned this activity? First thing is, did you plan? If you plan, did you go according to it? At times you would have planned, but most of the time you would not have followed. You would have revised it if time permits again. That is also question mark. Okay, so rarely we write down the lesson plan. It applies to most of us. Okay, there might be few exceptions, sorry. Okay, so rarely we write down and these things, but as experience our lesson plan is integrated here. Okay, these are called as memorized lesson plans. Okay, memorized lesson plan. Suppose if you want to take some topic, okay, we would have planned so that it will come as a flow, right? So these are called as memorized lesson plan, but it has got its own disadvantage. Advantage being, because of our busy schedule, somehow we can tweak and we can perform our activity, but the disadvantage is always we may miss out lot of things, because we will know, but at the same time we may not execute each and every step. Okay, so this is the difference between memorized lesson plan and actually written and followed lesson plan. Okay, okay, so what is lesson plan then? So it is a written document. Okay, it is a written document of educational objectives. Okay, it is a written document of educational objective to be realized. This is very, very important. It is not just written down document. It has to be realized or it has to be executed. Okay, and specific means by which these are to be attained during the lesson. So to stick to that execution, we need various other things. Say for example, we need tools, we need media, we need time and space, right? Do you agree? If the document is ready, can we do it? No, it is just cutting the entire thing into bits. Say for example, we need a space, we need a lecture hall, or we need a demo room, depending on the activity, right? Okay, then we need media, LCD, OHP, whatever, blackboard, and tools. Say for example, if it is a procedural skill, various other things are required, materials are required, checklist is required, all those things. And most important thing is manpower, that is we, and the time, okay, to execute that. So this is all about lesson plan. So it is a written account of educational activity to be realized and by specific means by which these are attained during a lesson. Okay, conventionally when we say a lesson plan, generally it is designed for 40 minutes because studies have shown that the attention span of a large or any given student hardly lasts for more than 40 minutes. Okay, usually it is planned in one session because it is always better to have lesson plan for this period if it is a big competency to be achieved. Say for example, you may have to teach a competency, but rather than having a lesson plan for the entire competency, if it has got 2-3 hours of teaching, so it is always better to split into different lesson plan, which hardly lasts for 40 minutes, because the way we execute each and every information needs to be accounted. So that is the reason why it is always better to plan for 40 to 60 minutes. And also we have something called as micro teaching. During your PG days, you would have done this micro teaching. So for that, at that time we will hardly speak for 10 minutes. For that also we can have something, what I can say, lesson plan in our mind. So this is regarding the conventional as well as micro teaching lesson plan. Okay. What are the advantages of having lesson plan, or what are the advantages of writing down this document in day-to-day practice, so that our training or execution of this class is achieved or it is done in an effective way? Can I have some thoughts? You won't miss any points. So whatever you would like to, or whatever you would like to teach or train can be planned. That is one important thing. Then time management. Very good. Time management. If we have set document to address each and every specific learning objective, that is the greatest thing. So it is merely a planning. Then any advantage?
At the end of the class, what are the points he has to retain by the students?
Yes, exactly. Because at the end of the class, so you can see whether you can evaluate rather in the class itself whether the student has understood, whether we have given importance to all those things. There might be some important things which has to be emphasized more. So we can look it back, or we can have our own feedback. Okay. Then any other advantage? Any other? Huh? Yes, exactly, because it is in 30, 40, 45 minutes time, it is always, the flow is very, very important. So sometime you never know, because of so many pressures, we may also go blank. Okay, if everything is planned, if those things are there in PPT, then it is very good. Okay, so let us see some of the advantages why we need to have the lesson plan. So it helps the teachers in formulating the learning objectives. Okay, we can formulate the learning objectives, TL methods, teaching learning methods, and also we can arrange how this has to be taught with appropriate tools. Okay, then prepare and organize the contents. Okay, so you may read, okay, you may read about that lesson plan, but what is important message to be conveyed to the student, you can organize the content. Okay, then it reminds the teachers to arrange suitable AV aid. Of course, it is very important, and other resources, because when we are taking different lessons, we may require different sources. Say for example, we may require some video clips, as madam told, during, if you want to show the surgery, or any other activity to be procedures, so we may have to arrange some video clipping. It has to come in appropriate place. Okay, then it makes the presentation orderly and appropriate. It gives a neat presentation. At the end of the day, or as we progress, we enjoy our teaching, right? So each day, if we do the things in an appropriate way, it gives immense pleasure for us. Okay, it makes our presentation orderly and systematic. Then it helps the teachers again to remember the content. As she told, the flow will be there. Time management, very important. Time management helps the teachers to evaluate the learning outcomes. That also someone has pointed out rightly. So this is about the other advantage, and it improves the effectivity of the teaching and learning. It is not haphazard. I think each one of us had our own experience as students during our formative years. Some are very good, some will come prepared very nicely, okay, and some may just come in very busy this thing, and they may take some 20 minutes and they may leave, all those things. So those are the limitations can be curtailed to a great extent. Okay, then it facilitates self as well as peer assessment of the teaching and future improvements. So nobody is perfect. How much ever we plan, there is a scope for improvement. How best I could have addressed this particular SLO in a different way or in a better way. There is always a scope for improvement, and also over a period of time with the change in curriculum, okay, with the change in the advances, lot of drugs, new procedures, all those things coming into place, it gives a scope for upgrading the written down document. Okay, I hope it is very, very simple, just making it or giving it more thought to it, that's all. There is nothing new in it. Okay, so these are the advantages of lesson plans. Okay, then when we draft a lesson plan, we need to follow some do's and don'ts. Okay, so rules have to be followed. Some important things, it should be relevant, clear and feasible. Okay, you should not write down a lesson plan which is not feasible to execute, right? No point in writing down such lesson plans. Okay, it should be very clear. It should be very clear in the sense that whatever we have written down, it must be in an executable form, and also there is in a system there is always new people who are joining, for them, or new as well as some junior faculties will join. For them it will act as a guide, so as to prepare oneself, because those people are not exposed to the learning. So for them it will act as a guide. Okay, it should be flexible. It should be flexible. This is also one important thing, as it was mentioned during the buzz activity. There should be some scope for the teacher, so that in 1 hour teaching session something it goes out of the way, some disturbances from the students or some way it may go out of the way. So there is scope for the teachers, some sort of flexibility and allow freedom for the teachers. Then the main don'ts are, it should not be too exhaustive. Okay, the opposite of that, it should not be too exhaustive and detailed, and at the same time it should not be too short also. Appropriate, feasible, it gives one's experience we can judge whether it is feasible or not. So that is the important thing you have to remember, do's and don'ts. It should be flexible, it should be clear, feasible, and at the same time it should be adequately having all the content addressed in an appropriate manner. Now let us move on to the types of lesson plan. Okay, very simple. So we have to have lesson plan for addressing the knowledge domains, that is the main where we are helping the student to acquire knowledge. Okay, acquire knowledge, cognitive domain, and also for various skills. Say for example, it could be a procedural skill or it could be a communication skill. For that also you need to have. Okay, you need to have the lesson plan written, so that it over a period of time everything will fall into place. Okay, so it may not happen overnight, but it is a process. It is a process. You can stick to those lesson plan, you can always modify if needed, and with the advent of time some new things will come into picture. Okay, so these things, if you remember, it is my own experience rather. So when we started our career, in the mid part of our career, and if you see right now, there is a lot of changes. These concepts were there but difficult to execute during that, but with the time, maturity, we may able to do it in a simpler way, all those things. So in nutshell, we have two types of lesson plan, one for the knowledge domain lesson plan, mainly for the large group teaching and also for the small group teaching, and for the skills, procedural skill as well as communication skills. Then what are the elements? This is the crux of drafting. You should at least you should know these things. Okay, it will have various sections. Rather, in the top of the written document, you should mention a lesson plan document should contain which is the subject, which is the topic, okay, class, duration, okay, competency to be taught, okay, which competency you are going to address it. Okay, then for that you need to have specific learning objective written. Okay, so with the little bit details on the regarding the all those things, subject, topic, duration of the session and all. Then the competency, previously we used to write, before CBME we used to write the general objectives. After 2009 we started giving the numbers, competencies, all those things. So we need to address which competency we are being addressing in this particular document, that should be there. Then specific learning objectives. So in that particular session, what are the things you are going to address it? So that has to be written down. Then comes the instructional elements in which how you are going to address each and every SLO has to be written. Say for example, I will explain with one particular example here. Say for example, if you are I will take the same example which I am going to show you. Say for example, you are taking a class on UTI. Okay, first SLO is at the end of the session, the final year part 2 student should be able to define UTI. That will be your first SLO. How this SLO will be addressed in the instructional components, that is in the content, is you write down a small definition of UTI. Okay, so definition should be entire, it is not half or something like that. That has to be, because when we are giving that definition, we may take some time to explain the definition as such. So that has to be accounted. Time has to be allotted for that. Okay, having defined the UTI, then next comes the types of, list the types of UTI. Okay, so you can give the or list the or enumerate the types of. Okay, there are only two, not enumerate. List is upper urinary tract infection, lower urinary tract infection. What comes in upper urinary tract infection, what comes in lower urinary tract infection. Those things should be written. Okay, otherwise whatever SLO you are going to have in the top portion, same thing you are copying in the instructional this thing. So, and in the instructional component, not only the brief thing, but also how you are going to address this, whether you are going to narrate it or you are going to explain it or you are going to show some videos. Okay, all those things should be written, and also in the last column you have to write down how much time you are going to take. It is just for not only for the sake of completion, just to align your time in that 60 minutes, whether you can complete the entire thing. Okay, then as I told earlier, the teaching learning method should be written for each and everything. Of course, here once it comes, it is large group teaching or small group teaching or any procedural skill which is taught in the bedside or something like that, that has to be addressed. And time, as I told earlier, has to be mentioned. Then there should be evaluation method. Evaluation method should also be mentioned in the document, so that when we are evaluating at various point of time, we already have this document in place, so that we can make use of this lesson plan for the evaluation purpose also. Then after that, follow-up action. What follow-up action we have to do with respect to this lesson plan. I forgot one or two important points here. In the after this, before evaluation, in the evaluation section itself, you can have some question written for that particular competency. Whether that competency you need to have some large, long essay questions, short essay questions, MCQs. You can mention there only, so that it helps during your assessment time also. So there is already some questions are there, and these questions can be discussed in the class, so as to make it interactive. You need various, say for example, after 20 minutes or so, you need to have a break. At that time, you can put one question. If it is already there in the document, if you have planned, you can put the same question, so that it can be made interactive. Okay. Follow-up action, again, you have to revise it through different means. Say for example, it can be discussed among the faculty members. It can be in our previous institution, we used to send the lesson plan to the other universities. So there is peer evaluation of the lesson plan will be there. Okay. So because we are thinking from one dimension, what others are thinking we don't know, and what good practice the other university used to follow, we never know. So for that reason, we need to have a follow-up action by giving constantly sending this thing lesson plan design to other institution or organization, and also sometimes it can be shared with the students also. Okay. So these are some of the elements of lesson plan. Okay. How to prepare it? Okay. How to prepare it? So it can be, the source can be our NMC documents. So they have given various competencies to be addressed by each and every, has to be addressed by each and every department, right? So there are certifiable competencies, non-certifiable competencies, all those things are there. So you can take from that. So broader competency can be broken into smaller topics, and it can be addressed in different session. And for each of these small topics, you need to have a lesson plan. Actually speaking, you need to have lesson plan for smaller topic also, so as whatever duration of time you are going to address, it has to be there. Then, and as I told earlier, it has to be separate for skills as well as to address the cognitive thing, because the way we approach these things are different, right? So for procedural skill, some explanation followed by you may have to demonstrate it, all those things. So that is a different story. Okay. Then prepare the specific learning objectives. So again, you need to discuss with your department people, and how once you draft it, it has to be vetted in the department whether it is appropriate or not, all those things. Okay. It also once we draft the SLOs, it should also contain the TL method, the tools, media, all those things has to be identified. Okay. Then lesson time should be mentioned. Say for example, ideally 40 minutes, sometimes it may not stop at 40 minutes. We are very what I can say, fond of utilizing the time, which may not be so for the students. Their attention span goes out after 40 minutes, but enthusiastically we will prepare 50-55 minutes without giving scope for taking attendance also, but it should not happen actually. Ideally 40 or 45 minutes, so that you always have time in your hand. Okay. And also once we come to this forum, time is immaterial. We don't keep the track of it, right? Okay. Then most important thing in a didactic lecture is set induction. So 8 o'clock class, they would have woke up by 7:50, and without having anything they will come. So they are still in that, what I can say, they are to be aroused. Okay. So you need to have a specific set induction thing. Okay. So which will make the students very interested. They can be aroused, okay, they will take part in the teaching session. Just to give one experience of mine, so all of us are quite familiar with the designing a sect induction. Just so today I am going to take one class for the second MBBS students after this. So I thought I will share that example of setting an induction. So this is not only the example, it is my own experience rather. Okay, where is it? Okay, so it was my mentor-mentee session in which my mentee just I observed some abnormality in him. So he was not looking to me during the session, he used to look somewhere else, and when I interviewed or spent more time, he revealed so many things. So it happened way back, 1.5 decade back, okay, 15 years back. So 21-year-old medical student revealed he had difficulty in swallowing of late. Okay, so something is sticky while swallowing, and also I noticed his eyelids are having some problem. It is he never used to open his eyes properly. I noticed some strange thing, and also he was looking somewhere else. And upon inquiry, he told that since 1 or 2 weeks, all the images are distorted. He can't see the things properly, all those things. And then I called my friend who was working in neurology, and I revealed this is the problem. So just you can have a look. And to my surprise, he had some mild degree of myasthenia. So he had ptosis, he had difficulty in swallowing, he had diplopia symptoms, all those things, and promptly it was intervened. He was started on 2 drugs rather. So I am making that as a sect induction. He was put on medication X and Y. Okay. So after 6 weeks or so, his symptoms improved. Then the X was tapered and Y was continued. So today I am going to take anticholinesterase, please bear with me, except Abra, okay. I am going to put this because we are using various drugs like pyridostigmine, all those things. I am going to use this scenario as a sect induction, okay. So you can have your own experience or your own case which you are going to see in the hospital as sect induction, okay. Then another thing is, after 20 minutes, you have to break the monotony. Have some idea for that. Whatever lesson plan question you have prepared, you can project that. Suppose if it is already covered. Okay. So that, and also you can plan other activity. You can take the attendance also during this 20 minutes break. You take the finished attendance so that they becomes very attentive, because for that only they had come, right? For attendance only they had come, that with the great difficulty at 8 o'clock. So it is better to take attendance at 8:30, okay, so that nobody will feel bad. My number I have not told properly, whether sir has not noticed my number, I would have marked absent, all those things. Okay, so all those things can be addressed. Okay. So lesson plan should be used as a roadmap or a guide, and it should not act as like this. Okay, it is just a roadmap. Of course, we are relying on lesson plan, but it should not be too much rely on the lesson plan. We should not use this as a crutch. Freedom should be there, which I have already told. Okay, and finally, the revising the lesson plan. It is a dynamic structure. It should be open. You should always open for improvement or feedback, because of so many things. Curriculum changes. Okay, there will be new certifiable skills added to our curriculum. Some of the things goes off. Some new drugs have to be discussed. New procedure has to be discussed. So you may have to make this as a constant practice. Feedback should be obtained from your department people, experts, as well as even from the students. Okay. Now, having discussed this, lesson plan, let us see one of the lesson plan. Okay. I think this is one of the this is what I can say, competency in general medicine. Okay. So name of the teacher should be there, class should be mentioned, number of students 150, date has to be mentioned when it was prepared, duration of the lesson plan, say for example 40 minutes or 50 minutes, subject internal medicine, topic fundamentals, it is general thing, fundamentals of UTI. So competency, just I have given a vague number, IM 12.4, it is not exactly matching with that. Okay, just to make a note of how the different things have to be in the place. Okay. Then learning objectives, specific learning objectives for this. At the end of the learning session, the phase 2 part 2 students should be able to define UTI, list the common bacteria causing UTI, list the types of UTI, list the common bacteria causing UTI, describe clinical features of different types of UTI, because as you know, upper and lower may present in a different way, that has to be addressed. Describe normal predisposing factors for UTI, explain the pathogenesis of UTI, what happens, then discuss the epidemiology, what is the prevalence. This is general, please remember, I have not addressed so many other things related to the management and all, because it is the fundamentals of UTI. Okay. Then you need to have a set induction case, interesting case you can mention. Then comes the instructional components. So SLO, each particular SLO, how you are going to address SLO, content, time, method, or how you are going to address these things. So first one, in the content you have to give the definition, just 5 minutes you can finish off. How you are going to do? You have to narrate it. It is as the TL method is, this particular lesson will be addressed in large group, 150 I have mentioned. So you need not mention LGT everywhere. So some place if you write LGT, large group teaching, it is sufficient. Of course, some of the SLOs you may have to mention how you are going to address it. Say for example, when you are talking about specific learning objective 3, that is list common bacteria causing UTI, then you may have to, you can ask the student, what are the common bacteria, because they are final year part 2 students, they have studied microbiology, they have enough idea regarding this. Okay, so you can derive answers from them. So it is some sort of question answer, then you integrate that. Okay, because the answer won't come as you wish, right? So you integrate in such a way that, so these are the gram-negative bacteria causing UTI, these are the gram-positive cocci going to cause UTI, all those things, then you can organize. So that is the meaning of deriving answers, and you are explaining later in an appropriate manner. Then the fourth one is presentation, that is clinical features of UTI. You can mention narration with the PPT, anatomical factors and biological factors, who are susceptible, all those things. It is subject, I won't go into the detail. What is more important is you have to identify MCQ, short essay questions, or if it is given as a, this is not a long essay question competency. Okay, either MCQs as well as, if appropriate, short essay question can be identified and it can be documented. And what are the continuation of thing? See, this is very, very interesting. You can make them understand in a better way, so that follow-up assignments are ask the student to collect at least 5 cases of UTI. How collect cases of UTI means starting from the case sheet itself. very brief case sheet including age, gender. It gives an idea, okay, in which age group it is common, gender, all those things, how it is presented, what is the diagnosis, whether it was upper or lower pyelonephritis or it is simple prostatitis, all those things. Then they can also look into the lab investigation asked, whether only microscopy was asked, if it is an upper UTI, even blood culture was asked, what are the organism isolated, what is the culture sensitivity report, and what drugs are used, for how long, all those things, 5 cases. It gives a very, very appropriate or complete information regarding the UTI. Okay, this is the follow-up assignments. Okay. Then, as I told earlier, for communication skill also, you need to have a lesson plan. Just briefly, I will go through this and I will conclude my session. Okay. So, here actually it is not microbiology. I think it could be a surgery, this thing, what competency. Okay. So, you have to mention the name, class, all those things. If you see the number of students, it is 50, it is small group, or even it may be still smaller. Okay, because it is the communication skill you are going to teach, it may not be appropriate for 150, or it could be even for 10 or 20 students. Okay, it is not microbiology, it could be surgery. Okay, the topic is collection of urine sample by MSU, midstream urine collection. Okay, competency simply I had given, it is not microbiology, it is surgery, I believe. Okay, then specific learning objectives, here in communication skills, it is, if you give 1 or 2 SLA, it is more than sufficient, because here you are going to tell more and explain and demonstrate, and or you may have to ask the students to do it by appropriate means. Okay, here explain how you are going to communicate to the male patient in collecting his urine, and similarly for a female patient. Okay, set induction, again you can give a case vignette of improperly collected midstream urine, what happens. Say for example, there will be different pattern of organism which are not causing the UTI, right? Okay, so you can put this thing, because patient is experiencing symptoms but the organism isolated were different, you can just show a report of that improperly collected. Okay. Then, so content, procedure indication. So what are the indication for the procedure, what are the procedural complication, all those things you are going to do. So first describe it through appropriate means, some 10 minutes can be allotted. So evaluation plan can also be mentioned here, how you are going to evaluate, short answer, and procedure checklist. For communication skill, you have to first, when you are teaching, you need to stick to the checklist, so that whatever we teach in different way, the same thing will be followed, and same thing we can make use for assessment also. Okay, so you have to have checklist for this, and you can show the video how it is being told to the, because it is a communication skill, how it is being told, all those things you can mention. Okay, so this is the checklist, what are the different aspect of how we are going to communicate with the male patient. Okay, that has to be written down, same thing has to be told initially, then you can show some video how a doctor is communicating with the male patient. So you need to have mark pattern also, because you are going to assess this skill. So which are the most important thing, you can give more weightage. Otherwise, if you have 10 points giving 1 mark for all those things, it won't serve the purpose. If the student has forgotten some important thing, it is not appropriate to give more marks. So here I believe, it is my prediction, wash the area around the meatus with sponge moistened with soap solution is important. Again, rinsing is also important. So higher weightage was given rather than compared to the rest of the things. Okay. So in summary, so lesson plan is a written document or written account of educational activity. It helps in teacher in training the trainer in many ways. It is a dynamic document. Okay, it is a dynamic document, needs to be revised at appropriate time by various stakeholders, right? Okay. There are separate lesson plans for addressing different domains. Okay, it should have contain various elements, or it contains various elements. So we have already discussed the different elements. Say for example, mainly the specific learning objectives as well as instructional components with how it is being taught. These are the main important things. I hope it is a very simple thing, but there are small important things are there. If these things are taken into consideration, our delivery of the teaching will improve. Thank you. And different universities or different college may follow a different pattern, but nutshell is it is same. We need to have plan, we need to have some question bank, we need to have some plan for the assessment, and also if required you can also mention the reference book in the bottom, so that it gives an idea for the other people to follow it up when you are not there or when you are not taking the class. Thank you.
Next. 10 sir.
10 that?
10 like that. 10 to.
10 to. Extend it. Whatever competency which I have shared for the first day, you can design lesson plan for the same. So we have derived the specific learning objectives for the competencies which have been given. Then you have identified the teaching learning methods, and also you have identified the assessment method. And for that competency, you can have a lesson plan with the standard. Same thing. And also for yesterday, sir has taken MCQ. So whenever you have the question bank, you can follow that main question, second question, MCQs, so that the competency is addressed appropriately from competency.
మేడం ఆడియో కావాలా?
Good morning, everyone. Good morning. Okay, at least say hi. Hi. Okay, so today my session is on assessment of skills. So yesterday we learned how to teach skills. So almost the same types of skills. Today we will learn how to assess the skills. So the objectives for today's session are: we should be able to describe the methods of skill assessment at the workplace. That is what we are learning about. How to use a skills lab to assess the competency in skills, and how to design a skills assessment station. So there will be plenty of activities even today. So what is the purpose of assessment? Why do we need to assess? Over the last 2 days we have learned a lot about all aspects of assessment. So can anybody just Tell me, what is the purpose of assessment? Why do we need to assess? And what do we need to assess? How much they have learnt, okay? How much we taught, okay? What needs to be improved? Anything else? Fill the gaps, okay? So fill the gaps so you will know when a feedback is given, so you know where we have to improve or where the student has to improve. Anything else? Want to know the progress, very good. Okay, to see whether whatever technique has been learnt is rightfully done or not. Feedback. It's okay, at least they are participating, I'm happy, whether AI or not. Accountability, okay. What do you mean by accountability, sir? Yes, sir? Cheppandi. Yes, sir? Sorry? Finding lacunae and to improve on that. This group?
To what extent we have achieved our specific learning objectives?
Okay, so this covers all aspects of what is the purpose of assessment. Is assessment easy? Assessment is an easy job for the assessor or for the one who has to be assessed? It is easy for the student, you mean? So now that we are all teachers, we think the other way is around. How about when we were all students? It was the other way around. What for them? They'll just write some questions and go. Okay. So anyway, that debate exists. So basically, the purpose of assessment is first learning happens, and then you assess, and then you give feedback. Again, learning happens, so it is a continuous cycle. It improves the learning process of the student as well as the teacher. But what is the overall output? When so much of learning is happening, it gets better and better and better, isn't it? So it gets to a very refined level, which continuously keeps changing depending on the type of students we face on a daily basis. So to discover the worth and also to improve the quality. Why do we need to assess? Okay, all these things. Other than that, there are some very important points. Why an assessment is required? Now you said to pass an exam 50% is required. Why that 50%? Minimum standards, yes. To achieve a minimum standard, assessment is required. Next. Yes. To keep the students motivated, yes. Very good, sir. How much they understood. Yeah, so all these things come under one word, to ensure competence. To ensure the competence. And somebody said to pass. For progression in academic career. So, for qualification or for licensing. You've got an MBBS degree, that is a license for us to practice. Very important, because we are all clinicians, to ensure safety of patients. So what do we measure? Like you've already told, clinical, here in this session, we are learning about how to assess skills. So in skills, what are all the different types of things we measure? Clinical examination of patients, interpretation of clinical data is another very important thing. A very, very important thing which is very difficult to assess is how to manage emergency situations. And again, another very important skill, how to assess communication skill. Yesterday I showed you a checklist. Does anybody remember the name? It's called as a Kalamazoo declaration or a Kalamazoo checklist to assess communication skills. What is Miller's pyramid? Any idea? Knows, knows how, shows how, does. So where does skill come? Okay, that is independent skill. Assessment of skills come in? The third, that is shows how. So shows how, or the skills performance comes at the third level. And the first, the topmost is performing independently. So the first level is knows, that is cognitive aspect, only knowledge based. Then knows how, applied. Then comes shows how, that is performance of skill. The student is performing the skill and you have to see whether it is done in the right way or not. So what are the various skill assessment methods which you all know of? OSCE, OSPI, Mini CX, then DOAP, DOPS, portfolios, logbook, okay? Okay, case presentation, done. Pedagogy, okay, for teaching skills. That's pretty much it. So we have OSPI or OSCE, and there is a variation called OSLER, which is a longer version of OSPI. Then there is Mini CEX, and then there is DOPS. Other than this, we have assessment of communication skills, something called as a 360-degree assessment, and portfolios. So I will be talking about OSPI and OSCE essentially. So what do you understand? I'm sure all of you know. Can we have just some inputs from your side? What do you mean by OSPI or OSCE? There is a checklist, time bound, stations are arranged. Is it structured? Structured. It is subjective or objective? Objective. It is exclusively objective. So there is a checklist. Very important is the checklist which is agreed upon by all the examiners. So to a large extent, we can avoid bias. Okay. So basically OSCE, see, it's not that we don't know how to check BP. We have all done, isn't it? There was no OSPI or OSCE at that time. So the routine procedures which are done, which is validated with a checklist, is nothing but OSPI. So what is OSCE? Performance-based testing used to measure the clinical or practical competence. It was first described by Harden and Gleason from Dundee in 1985. There are some procedures which I would like to show in our day-to-day life which happens without a checklist. So many people teach us so many things, but there is no checklist and there is no validation for that. You just learn the skills. What's happening here? Father is teaching the son how to tie a shoelace. Do we have a checklist for this? What can you see here? Chopsticks. The parent is teaching how to use chopsticks. The boy looks very annoyed, isn't it? So can we have a checklist for this? We can have a checklist for this. This is one terror, isn't it? Yesterday many people told they are scared of driving. So they actually have a checklist. Unless you have some influence or whatever, that is different. But this is the way it is usually done. Where the parent teaches how to make a dosa. But somehow he has got something. Or I don't know, the image was clicked like this. So how do you define OSCE? It's a long definition, but the gist is we all know about it. So what does the literature say? It's an assessment tool in which components of clinical competence such as history taking, general examination, simple procedures, etc., including communication and attitude, are done using, see, the word is very important, agreed checklist. Whatever checklist we make, it should be accepted by all the observers. Supposing there are 10 stations, we need 10 observers. So all the examiners or observers should agree to the checklist already made, and the student rotates among various stations. So the full form of OSPE is objectively structured practical examination. So it's objective, the examiners use a checklist. It is structured, so every student sees the same problem, performs the same task in a fixed time. So there is absolutely no bias. And because it is either practical or clinical, so the task will be representative of that particular competency. E stands for examination. Now how does OSCE differ from the traditional way of examination? Traditional examination doesn't have a checklist, so it is not structured. Anything else? Bias, very important aspect. Next. Subjective, yes, subjective, bias. Time, so which will take more time? Traditional method, it can take more time or it can take less time, we don't know. So there is no specific time limit. Yes, sir? Variability, okay. Student doesn't know what is being assessed. Oh, okay. Examiner also won't know. Bias, okay. Anything else? OSPE is standardized, okay. Yeah, so the same level of questions is not there. So each candidate gets a different question depending on the examiner's mood and his perception of how the student is. Any other thing, one important thing? Assessment is easy in OSCE. Okay, because it is objective, they don't have to talk, they will observe and they will give the marking. Now we saw the example of a shoelace. Father is teaching the son how to tie a shoelace. So let's have two scenarios. One is the traditional and one is the OSPE or OSCE type of a checklist type of a thing. So supposing the father says you tie the shoelace, I'll come and see. So he goes away and somehow whatever, either he does it or he doesn't do it. So the answer is like yes or no. Either he has done it or he has not done it. The effort which goes into it, the individual steps which go into it is not given any importance at all. So if it is an OSPE, say there are 5 different points in which you have to tick. Checklist is there. So only say supposing the last point he is not doing, doesn't mean he doesn't know anything. So the steps, individual steps are given importance. It's like a mathematics problem. You all remember the algebra, those nightmarish, you have those full page. So even if the answer is wrong at the end, out of 5 you get 3.5 or 4 marks. They won't give you. We used to fight for that. We're like, all these steps are correct. Please consider and give me 2 marks at least. So OSPE is something like that. Individual step at every level, the competency of the student is tested. In traditional method, importance was given only to the outcome. So that is one main difference, and all the other points you have already told. So there is student variability, patient variability, examiner variability, all the points which you said, subjective, bias. They might not ask the same set of questions to everyone. Some examiner might be very strict looking. You say some examiner is favoring girls, somebody is favoring boys. Whether you answer or not is a different question. But the kind of things go around are all this. So the final conclusion is given importance in the traditional method. Whereas in OSCE, it is different. Traditional examination evaluation is subjective and mostly tests only the cognitive domain. But OSCE is not like that because it is a performance-based examination. You examine all the types of skills to attain a certain outcome. So what is the methodology? How do we conduct an OSCE exam? All of you must be doing it, so let me get some inputs. How do we conduct OSCE exam? Stations. So what is the first step? Supposing, say, in your own subject, if you plan to conduct an OSCE exam, what comes to your mind first? Prepare the checklist. Okay.
Then divide them into small groups.
Okay.
Then allot them specific stations.
Yes, for all this, first we should think what you have to assess. The topic. Think of the topics which you have to assess by OSPI or OSCE. Ayin tarvata cheyaru. First thing is you think of the competency or think of what has to be assessed. Because see, you can't have all the competencies, all the topics cannot be assessed by OSCE with a checklist. Not some competencies might be very long, some might be very short. You will not be able to make a checklist for that. So first decide on the specific learning objective which you want to assess by OSCE. Yes, and then decide how many stations you want, think about how many examiners you want, how many students will come, like he said. First decide student whether they will come or not. These days that is the trend. Even if there is an exam, students don't turn up. I'll give you an example. First year it's only 1 month. Very detailed, we did one integrated session for a week. And for that assessment, after all red carpet welcome, warning, soft skill, hard skill, after everything, 45 students were absent out of 150. So student attendance is a very important thing. Anyway, so the method is, once you set up all the stations, the students rotate through each station. Each station has got a specific time limit and there is a certain order in which they have to rotate. The stations will include all these types of skills. A procedure station, a response station. Response station means you give a problem or you give something like an X-ray or some lab investigations and ask them to interpret and write it. It's like a question and answer station. And then there is a rest station. Supposing there are 20 OSCE stations, after every 5 OSCE stations there is a rest station. There is something called as a must pass station. Pass means to get 50%. So in the must pass station, we have a core competency. It's like the student has to pass that. Even if he has scored very well in the other things and he is not passed in that particular station, he is considered as fail. So there are some must pass stations as well. This is an example of an OSCE station. You see the student is performing some procedure and you see the observer standing at the back end marking the checklist. Ideal number of stations would be 15 to 20. Time ideally 4 to 5 minutes per station. The students rotate through all the stations. Now just imagine there are 20 stations, each station 5 minutes. How much time it will take? 100 minutes. So close to 1.5 hours. So do we have that much time? So this is the standard one which is recommended, but we can conduct according to our setup and our convenience. This is another example of an OSCE station. Oh, what do you see here? Station number is clearly mentioned, and then what are the students doing? They are reading the instructions. So here comes the very important point. Whenever you design an OSCE station, what exactly the student is supposed to do there. That instructions should be very, very clear. It should be very clear. Whether they have to talk, whether they have to counsel somebody, whether they have to write something, whether they have to perform something. The instructions should be crisp and clear. And in that 5 minutes which you give for each station, it includes the instructions. They have to read the instructions, perform the task, and then move to the other station. What type of stations do you see here? Reading, X-ray. So that comes under which of the? Response station. They are not doing any procedure here. X-ray is there, some questions are given, they have to answer those questions. What is the other one? Can you guess? They are measuring blood pressure? Communication station. It is a communication station. What type of stations are these? Procedural. So what type of skill is analyzed here? Psychomotor skills. Psychomotor skills are assessed here. So I'll show you a sample of a checklist for OSPI. So supposing the question is, examine the specimen of urine for proteins. And the checklist, that is the procedure which the examiner has written down is, does he or she take a urine sample to 2/3 level in the test tube. So how many marks are allotted for that? Half mark. And then, does he or she boil the upper 1/3 of the column? For that you allot 1 mark. Next, whether they add acetic acid, another 1 mark. The last one is, does he or she compare the change in the top layer with the bottom layer of urine? So which has been given maximum marks? Last one. What is the total marks? No, 4 marks. 4 questions, 4 marks. So in these individual questions, it is up to the examiner to allot the weightages. Whatever you feel is the key step, you can give more marks. The starting step, for example, say take the urine sample, anybody will do it. Okay, so it depends on the examiner how to allot the marks for each of these competencies, each of these steps in the checklist. Now I'll just show you a model OSCE station or OSPI station. So the question is, a case history is given, I'll show you. In front of you is a parent of a child who is sick. A written case scenario is provided. Read this carefully. Write a prescription for the above case scenario in the sheet provided to you. So these are the instructions. So very clearly what the student has to do has been mentioned. All that roll number, and after writing the prescription, instruct the parent regarding the treatment and precautions. And then last step is to hand over the prescription to the examiner. So these are the steps. This is what the student is expected to do. So this is the instructions chart. So the case scenario goes like this. A 5-month-old infant is brought to the clinic with mild fever and runny nose. He's feeding well, but there is difficulty in breathing. There is no cough or ear discharge. The child is of normal weight, exclusively breastfed. He's playful but has a blocked nose. His lungs are clear. So the history is very clear. This is the sample checklist. So what is the total marks? 5 marks. So the total number of marks is 5. If you add up. So what is the different scale here? Completely done, 1 mark for that step. If it is partially done, you give half a mark. Poorly done, 0.25. Not done at all, you give 0. Okay? So what are the steps? Like we learned yesterday about communication skills and counseling and everything. Greeting the patient, explaining the illness, explain the prescription and how to give the nasal drops, what complications might occur, and what to do if there is a complication, and explains the need to continue breastfeeding. So remember, there is no standard checklist. We have to make the checklist according to our setup, but validated from all the examiners, whoever is going to sit. So I'll quickly summarize the steps of OSPI or OSCE. First step is to have, what is the first step? You should have clear objectives. Select the competencies which have to be assessed. In that competency, choose the most practical aspects, because that is what you can assess beautifully by OSPI or OSCE. Of all the tasks, select the task for assessment in the current examination. Break that task into sub-tasks, like how we made the checklist. Assign scores for each of the task and the time. Set the time limit given for each of the tasks to be done. And then you set up stations. Okay? What do you see here? Okay. They are doing some, I think, fundoscopy. So the student is performing, but does he look like a real patient? I feel he is like a simulated patient. So for OSCE stations, we can have mannequins, we can have real patients, but real patients it's very difficult to get, they will not sit through for 2 hours. So we use standardized patients. Okay? This is another skill done on a mannequin. It is done on a mannequin. So this is how the design of OSPI stations looks like. So you have 10 stations, and you see the observer is placed at only few stations. In a response station, you don't require an observer, because they see the question, they write the answer, hand over, the examiner has to evaluate the answer sheet. For that they don't have to sit there. So there are rest stations, response, procedure, communication stations, so and so. Okay. What are the advantages of OSCE? Can we summarize? Objective, structured, time bound, standardized, no bias, isn't it? So individual competency is tested, the scoring is objective. For acute cases, say for example a case of MI, we cannot bring a patient of MI and assess, isn't it? So a simulation scenario can be used for acute cases to see how the student responds in case of an acute scenario. So OSCE can be used to evaluate such scenarios. This very important aspect, variability, can be eliminated. Large number of students can be accommodated in short duration of time, comparatively, I would say. What are the disadvantages? Planning. It requires a lot of planning. Anything else? Resources? Yes, examiners. Examiners, okay. Anyone, anything else? So resources, more examiners, more planning. Sir? Yes, correct. Complex skills cannot be assessed. For that we have Osler or other forms of assessment. So complex competencies cannot be assessed using OSCE. Okay. So it has to be carefully organized. Breaking clinical skills into individual competencies in itself is a big task. It takes a lot of time. Observer fatigue. Imagine the examiner sitting for 2 hours. Just sitting quietly without talking. Very difficult, no? Logistic problems. So these are some of the, I would say, day-to-day problems which can occur, but all this can be overcome, isn't it? If we really want to do it, we can find a way to do it. Okay, so with that, I complete OSCE. Now, before giving the activity, let me just say 1 or 2 slides regarding OSLER. It's like a long form of OSCE. Like sir said, complex competencies cannot be analyzed using OSCE. So for that we have a method called as OSLER. It stands for Objectively Structured Long Case Record. So it is there are 10 items in this checklist. I'll just show you. So for history taking, 4 points are given. For physical examination, 3 points are given. And to plan the line of management, another 3 points are given. So I'll not go into the details of this. This is just to tell you that there is another method called as OSLER, which goes into a little deeper level of assessment for clinical skills. Just one word. What do you mean by professionalism? And how do we assess professionalism? What do you mean by professionalism? Grooming, okay, dressing sense, very good. Very valid point, I completely agree with you. Attitude, behavior, okay, all the ETCOM. Yes, sir? Ethics? Sir? What did you say? Please tell. Having knowledge, having skills, okay. Anything else? Somebody said well dressed, okay. That's all. What type of attitude? You said attitude, so what type of attitude? Empathy, daya, dakshinyam, all that, okay, fine. Next. Before all that, punctuality, excellent, I was waiting for that. Thank you so much for bringing that up. Punctuality, that is the most important thing, I would say. From that punctuality, all the other things will come and fall into place. That is my belief. Please tell, sir, don't talk among yourselves. Soft, polite. Prompt, okay. Polite, not always. Punctual, yes. Yes? Okay, very good. Attitude towards exam. Yes. Yeah. Okay, so all the words which you told are there in this? Honesty we missed out? Punctuality is not there only in this, no? So that is why I wanted somebody to tell. That's an image, I couldn't put it there. Okay. Now how do we assess professionalism? It's not every day we assess professionalism. It has to be inbuilt. And we have to build a culture with all this so that you set an example to whoever comes next. The Gen Z, what they say. One student came just 2 days back at 2 o'clock. Ma'am, can I talk to you? First year student. Not even 1 month into the course. And he said, I'm interested in research. So I want to do research. Okay, so you should not discourage. It's a good thing that he wants to do research. So I told him how it is done. There is ICMR, there is UGSRS, otherwise you can take the help of a guide and you can do everything. All that was done. Then before sending him, I took out his attendance. And 3 exams were conducted. So I took out the attendance of those exams and the marks of those exams. And we maintain attendance slips. So he never answers attendance on time. So you mark him as absent. After the class they come out and they say, I was present, sorry, I missed out. So we strike it and I mark it. And tell them this is the last time and next time I will not do this. So all that history I opened and I showed it to him. It's like you first, all these things have to fall in place. And then you can do everything else. So I'm really happy that you want to do research, but for that, you should attain a certain level of professionalism. So you build on that first. After all this, he says, okay ma'am, have a nice day. I just said thank you. I don't know, otherwise I would have just yelled at him, so I said thank you. Okay, then after this, there is something called as a multi-source assessment or a 360-degree assessment. Okay, this doesn't happen in our country as much, but in other countries, they mandatorily do this 360-degree assessment. That is, assessment by peers, assessment by other members of the clinical team. What do you mean by other members of the clinical team? Nurses, physiotherapists, your assistants, and everyone. Here we can't take it. If you say there is somebody else giving feedback on how you perform. But it is very much essential. Assessment by patients. Can you tell me what aspect? Yeah, exactly. Communication, empathy, how good you were to them, how nicely did you speak to them. That is what the patient will tell. A patient will not tell, my incision was given like this, my sutures were not done properly, your procedure was wrong. Nobody will talk about all that, I feel. So it is the way you communicate with them, that feedback the patients will give. Level of respect, yes. Well taken, yes, very important point. Patients will, first thing they will tell, 5 o'clock means the doctor is in the clinic at 5 o'clock. So that is one very, very important thing which I get. I don't practice, but whoever does, they say that. For students, portfolios is another important aspect of assessment. I will not go into the details. So these are some examples of skills in medicine and allied subjects. These skills can be examined using OSCE. Then there is some surgical skills which can be assessed in the skill lab or otherwise also on simulated patients. This is a very detailed schedule made for the skill lab, for skill teaching. It was made by Dr. Dinesh, I think for phase 3 part 1. For phase 3 part 1 students, this very detailed timetable was made. And I'm sure if this is followed strictly, we will definitely reach a level of standardized skill teaching. So now we'll have a quick activity, followed by that we can have the tea break. Very quick activity. What I want you to do is to design an OSPI station and make a checklist for the scenarios given to each group. Make a checklist for 5 marks. Make a checklist for 5 marks. I'll give you the scenario. So the scenario for group 1 is measuring blood pressure. For group 2, suturing a clean cut wound. For group 3, eliciting ankle jerk. Group 4, it's a written station. So the activity is write the prescription for amoxicillin for a 5-year-old child with otitis media. And for the last group, there is group 5. Take a focused history from the parent of a 3-year-old kid who has fever. So you design the station. In the sense, you can tell what are all the requirements for that particular station. Make a checklist and write the checklist on the flipboards, please. Minutes? Yes. You can discuss among yourselves. Please write the points of the checklist on the flipboards. And then you will have to present 5 minutes each. Savita? Okay, can we start? So we will start with group 1. So one of you can present the checklist. Please mention your topic and present the checklist.
So our topic for our topic is measurement of BP. So in that first step is introduction to the patient, who we are and what we are going to do, and tell the patient to take 5 minutes of rest, and taking the consent from the patient will be allotted 1 mark. And the next is the correct placement of cuff 3 centimeters above the antecubital fossa and all those things. We will give 1 mark for the correct placement of cuff. And next is the sequence of procedure of taking the blood pressure. First is the palpatory method. If the palpatory method is correctly taken, so systolic blood pressure is correctly measured, then we will give the 1 mark. So next is the correct placement of stethoscope and the auscultatory method will give 1 mark. Next, release of cuff and conveying the results to the patient, and also requirement for the future follow-up will be given 1 more mark. So the total 5 marks.
So thank you. Thank you, Dr. Sureka. So for introduction, greeting the patient and explaining, they have given 1 mark. Placement of the cuff, tying the cuff properly. Yeah. Introduction, consent, instructions. Yeah. Placement of cuff, 1 mark. Correct placement of cuff. Sequence, the sequence in the sense, first they have to do palpatory and then followed by auscultatory method. So for palpatory method, they've given 1 mark. Auscultatory method, 1 mark. Yeah. All the steps involved in correct measurement by auscultatory method. Position of stethoscope, releasing the cuff after checking the BP. Then conveying the results to the patient and thanking them and asking them for follow-up. They've given 1 mark. Any comments? What do you think of this?
టైం ఉందా మ్యామ్ అక్కడ టైం ఇట్స్ హలో
లేదు అదేదో నేను అట్లే మాట్లాడతాను.
ఐ థింక్ టైం ఐ థింక్ ఇట్స్ నాట్ మెన్షన్ టైం ఫర్ టోటల్ హౌ మెనీ మినిట్స్ దే హ్యావ్ టు అలాట్ ఫర్ ఈచ్ స్టేషన్.
Okay, so the instruction we have given is just make the checklist. So each point is, when you design hospital stations, you have to allot how many minutes it takes to take keep that in mind, and then they have to talk to the patient, explain everything. So you have to guide the station. That is not the task given, but it's a good
Grading of performance. Grading of performance, not grading of performance.
She went to say completely done,
Partially done.
Okay, so they are the score of 5
Scoring.
grade out of 5. But the other way of doing is finally whether they did this or not. Yes, no. That is another thing. Yes, no, or partially done the step. Correct? That's what you want. That is another way of grading. Okay, it depends. But they are given marks. That is okay to start with. Yes, good point. Yes.
Ma'am, so they have actually graded 1 mark each. For introduction, they have graded 1 mark. While the palpatory step is an important step, they have given 1 mark for that also.
Absolutely point.
Any points? Okay.
What they were concerned about. Yeah, we can adjust it, but all the steps you have written correctly. Anything else? This group. Do not worry about yours. You have to listen to them.
It's okay, no problem.
Everything is okay.
Why this has to be really nitty-gritty is because you're going to assess, hopefully very honestly, with all the professionalism of a teacher towards a student, so that the student learns. That day, in one of our meetings, one senior medicine professor said that many students do not know to take the blood pressure by the time they come to the final year. I'm sure all of you would have encountered the same problem with MBBS students. So you can't blame the preceding departments or the ahead departments. You have to take the blame partly on yourself for having not stressed the importance of taking BP by doing a very good nitty-gritty checklist and making them certify in BP. Partly our fault and partly the students' fault, because they think anyway they will teach me BP when I'm an intern. No. Why I should learn in physiology, why I should learn in my first clinical posting. So that attitude has to be corrected then and there. So if we make it seriously, implement it seriously, even for as something vital as a BP. Suppose you don't know to take a BP, how is the patient going to respect you? In fact, they'll put a board outside your clinic saying, don't go to this doctor. He or she doesn't know BP taking. So it has to be ingrained into their mind that this is a very, very important skill, and so much of importance we are given by so many steps. So the more number of steps you divide it, the more carefully you are assessing the student. Because if you club 3 things into one step, if you give 1 mark or if you give 0.5 mark, I don't know whether he has introduced himself properly, whether he's got the verbal consent, whether he's explained the procedure. So you see that. So you have to split it further and then give the marks accordingly. Okay, but very well, good attempt and almost near there. Big round of applause.
Thank you, ma'am. Okay, now we'll move on to group 2. The topic given is suturing a clean cut wound. Yeah.
Good morning all. So for this case we have provided the resources like suturing pad, different suturing materials, tooth forceps, needle holder and a scissors. So my first question is whether we are observing the wearing of glove or not, and then sterilization of the wound area. For this we are giving wearing of the gloves 0.5 marks and sterilizing the wound area 1 mark. Next, coming to the appropriate holding of the instruments and suture material, this is 1 mark. And correct steps of suturing, whether taking the bites on skin edges, distance between the 2 bites, precise approximation of skin edges and application of the knots. For taking the bites on skin edges 0.5 marks, distance between the 2 bites 0.5 marks, precise approximation 0.5 marks and application of the knots 0.5 marks. And lastly, dressing of the wound 0.5 marks. Yes, ma'am.
We'll start with this group.
Any comments?
Yes. Any comments you want to add, subtract, any of those mark steps?
Okay, they are happy with it.
Very happy.
Friends.
Friendly next table.
Friendly next table. Yeah.
Okay.
Any groups from here?
Anybody? Yes, Krishna sir. Madam, Muji, Yamini is there, surgeon. Everything is okay. Okay. Wow. Easy. Everything is okay. Come to all
So she added pre-sterilization, she added 1 mark, I mean half mark. Pre-sterilization, she added a 0.5 mark. After suturing, there's something called post-sterilization where we wipe with betadine. There is no marks for that. She directly applied dressing. We always do the post-sterilization, ma'am. We wash the wound again, then put a dressing on that. Whatever clean cut, we are still after this.
Okay, thank you.
maybe a consent, maybe a procedure, clean cut one. Ma'am, there it's mentioned as clean cut wound. It's not a model.
Question is not proper.
Question.
Okay. Should be there.
In the beginning only they said they are given a suturing pad and the instruments. Therefore, this consenting step they are bypassed.
Okay.
Introduction also they are bypassed. There is something called a hybrid model. Okay, so this happens in many of the licensing exams abroad for a surgeon. The hybrid model is there is a suturing pad which is with Velcro latched on to actual person, standardized patient's arm. If that is the station, then she has to explain, she has to get the consent, she has to reassure, and then the patient will ask questions, she has to answer questions. All this will be observed and that will be part of the checklist. That is called a hybrid simulation, okay, where actual standardized patient is wearing the arm pad and they will also make noise, oh that hurts, and don't hold my hand so tightly, all those things. So they will see how you react to that patient's response, and they will test your suturing also. That becomes a little complex scenario, but here because they said suturing pad, we have bypassed that. Okay, is that clear? Anybody else? Any facilitator want to say anything? Okay, so most of the steps, everything she has actually said anything very well, but which is the most important step you think? Or you think every step is important? Because everything you are given 0.5 marks, right? So correct steps of suturing you have divided into actually 2 marks, huh? 2.5? 2 marks. Okay. So taking the bites equally on either side, skin edges, distance between the bites, and approximation and application of knot without tension. Okay. And dressing of the wound. All right. Wearing of glove. Okay. So it's almost everything is there. Very good. The wording that you use English is the student or wears the glove. It should be like that. That thing is there. And then the wound is, he sterilizes the wound. It should be present continuous. Wears the glove, sterilizes the wound, holds the instrument correctly, takes the bite, like that. Okay? So that is English you have to change. But otherwise all the steps are there. Big round of applause.
Thank you, Dr. Babita.
Please take a photograph of this and I want you to put it in the group, WhatsApp group. All your OSCE checklist, you can go back to your own department and please use this as applicable to your own department. So don't think it is just an exercise for completion of BCME and certification. This is an exercise that you're going to follow and go back to your departments and please use it as applicable to the skills that you teach your students. Next group, quickly.
Yeah.
This is what?
Our station is eliciting an ankle jerk. The total duration that would be allotted would be 5 minutes, and the checklist points would be: first, greeting the patient, we have allotted half mark for that, and explain the procedure to the patient and obtaining consent from the patient, we have allotted 1 mark for that, and then proper positioning of the patient, we have allotted half mark for that, and then coming to the correct demonstration of the ankle jerk in the patient of both sides, of both the limbs, we have subdivided that into 3 subdivisions. The first point would be a proper exposing of the Achilles tendon. We have allotted 0.5 marks for that, and proper holding of the knee hammer, hold the knee hammer, and then tapping on the Achilles tendon. We have allotted half mark for that, and we have proper holding of the knee hammer. We have allotted half mark, and correct method of tapping the Achilles tendon, we have allotted 1 mark, and correct response of the ankle jerk, yes or no, whether we should observe a contraction of the hamstring muscles and also for the plantar flexion, yes or no. If elicited, we have allotted for that 1 mark. Total would be 5 marks.
Anybody wants to talk?
This group will start. The group next to them will start.
Anything you have to tell? Actually, what is more important is contraction of hamstrings.
Beautiful presentation. I mean, this is like, yeah.
No, let me speak. Contraction of hamstrings is more important than the movement of the ankle. Yes. Because in normal patients, getting that ankle jerk is easy. But in a patient who has some UMN or element lesions, the contraction comes first. So that has to be carefully observed. Next.
Exposure of the hamstring.
Yeah, they've written. That step is there, sir. That step is there. Yeah.
Okay, so
Exposure.
the hamstring should come somewhere there.
It's there, it's there.
Exposing Achilles tendon.
Okay, Achilles tendon. Sorry, hamstring is not there. Yeah.
Okay.
So exposing that, correct. Thank you. Well taken.
Right? Okay. Okay, just fine tune that. Anything else? First group. Yeah, physicians here. All are surgeons or basic scientists. It's okay. Okay, in these things, which you think is the most important step? You guys can also comment. Sorry, I missed you. Oh, see. We have to
If you explain the procedure, if you, ma'am, if you explain everything to the patient have a clear idea of what you are doing actually. So you have to deviate the patient for the correct jerk to happen. Have General 6 maneuver. Have to deviate the patient for the jerk to come correctly actually.
You want them to
General 6 maneuver so that ankle jerk will come.
General 6 maneuver is done when you are not able to elicit, so you reinforce. That time they do the, not for everyone. Oh, so he meant, that is the ideal method. That is the ideal method. Now his point is to make the patient relax. General 6 maneuver is done when you don't elicit and then you reinforce the upper motor neurons and then make the neurons fire. So that is different.
Okay, in this, my only comment.
Yeah.
Any other comment? Thanking them. Adale ellarum pass aidva meeting and okay, all right, because you're going to inflict some pain on the patient or some discomfort in that patient. Okay, yes.
So, in the response of ankle jerk, so there can we add something like the student giving what is the actual result of the test?
That's what they have to document. They have to see the response and say ankle jerk present.
No, what is the understanding of student? What is the understanding of student?
They have to say the ankle jerk, what is the final result? Is it normal? Is it normal, delayed, exaggerated? They have to give that. Maybe they should put that as the final point, interpretation of the response.
By the student.
Obviously.
Okay. Well done. Thank you.
Here, note this positioning of the patient, you are given 0.5 marks. To me, that is the most important step. If you don't position the patient properly for an ankle jerk, none of this you can do. So if you want to give weightage, many of the physicians say that positioning the patient for the ankle jerk is the most important. That should carry more marks than saying good morning and good evening. Okay, so that is what you should remember. Ma'am is there, she can correct us. She's professor of medicine, so positioning, the correct way to position the patient, I feel is the most important. So, but I think it's a very well done checklist. Big round of applause.
I'll move on to the next group.
Good morning. Good morning, all of you. Our allotted topic was write the prescription for amoxicillin for a 5-year-old child with otitis media. We have presented this way. For superscription, we have allotted 0.5 marks, which included name, age, sex, and gender. Patient biodata, patient identifiers, madam. And for the diagnosis in capital letters, otitis media, we have allotted 1 mark. For drug dosage and frequency, we have allotted 2 marks. Instruction to patients and parent, 1 mark.
sign, signature, APMC number, etc. 0.5 marks. 5, madam. Yes.
You don't want pediatrician to comment, you want others to comment. Anybody else? So you can also comment. Anybody wants to comment on this checklist? You don't return the white.
You don't look at that set.
You do my duty tomorrow. No
Group
comments?
1.
No comments, huh? Okay. You know the next group? Group 1, please, you can comment. Okay, you will read it out. Superscription, that is name, age, sex and
Wait, madam.
weight is the first point. How many marks for that?
0.5.
0.5. Second is
Diagnosis in capital letters.
capital, otitis media.
1 mark.
1 mark. Then drug, dosage, frequency, 1 mark.
2 marks.
2 marks. Instruction to parent.
Patient and parents.
Patient.
5-year-old.
Patient, huh?
Yeah, not
Wait. Okay. Next is signature.
Address.
Okay, all right, huh? Nice. Name, signature and APMC. Yeah, now you can criticize quickly. Okay, excellent. Wait. Tell. Carom champion will tell us.
Route of the drug administration.
Route of administration, where have you written? Checklist lab.
How many days?
No, you can't write very generic like that. You have to checking the student know whether it's written or not. So, route of administration also says duration of the, how many days you will write the prescription for?
Frequency you have mentioned. Frequency. Frequent times. Okay. Yes, ma'am.
Frequency, but how many days? Okay, very good. Excellent.
Dose and dosage.
And we have to write the drug name in capitals, and we have to write the we do not use the company name, we have to write the drug generic name.
Okay, very good.
Dose.
Any side effects?
Instructions.
All yours.
Side effects. Instructions should hold more marks because it includes more side effects and it should be taught in a clear.
Okay, listen to Abra, right?
Drug name in capital letters, sir.
She said that.
Okay.
Other than that.
And doctor's name, who has prescribed. That's it. Signature. There should be proper name.
Doctor's name and dot letters should be there. Okay, correct. Doctor's name in capital should be there.
And there should be any contact number if there is an emergency.
Okay, very important is below the prescription, please listen, don't argue. Abrar as a date they put, sir. Absolutely spot on. 2 points from this group extra is Ramakrishna sir says there is the patient identifying number, OP number. Okay, that has to be written. And Abrar says that, what did you say?
Doctor's name in capitals.
You should give a number in case you have to contact for adverse events, whom to contact in your prescription. We assume it's, no, doctor's phone number is not there, no, your name and APFC number is of no use. Okay.
It's actually good.
So please listen, they have one comment.
We don't know whether there is a history of allergy to that antibiotic previously or not. Penicillin sensitivity.
No.
0.25 like that marks.
You should look at dates. We'll come to the breakdown. 0.025.
Okay, sir is giving comments.
Anything? frequency, duration, drug, dose, duration, frequency of administration, and also most important thing here is what formulation. No, route is different. 5-year-old child, amoxicillin, what formulation you would like to, or dosage formulation? That has to be.
What again?
No. They have written, but they have not written what has to be mentioned. Instruction to the patient,
They have
please.
put it as generic instructions, they are going to tell all these points. So under instructions, please put these points. Okay? What do you paracetamol said?
When marks this paracetamol SOS in case of fever, we won't document it. You will document
Yes, it has to be. No, 5. It is always better to
See,
put.
sometimes when we say write it for 5 marks, you can make it the station for 10 marks and reduce it to 5 and the total marks comes. Because so many details are there, it's difficult to make 0.025 and all that stuff. It's up to you to design your checklist. So the checklist is not designed, now you understand. You thought 5 of you sat and made the checklist that everything should be alright. But 5 of you is not enough to make a checklist, you understand. It has to be everybody in the department. You can even ask other departments to give their contribution because they may add some very valid points like the first group has been adding. So this is just an exercise, nothing personal. This is a very good checklist, but we wanted more details under all these headings so that when you check the student, you are actually doing a thorough evaluation of the student. If he passes this prescription test, and without using any chat GPT, AI, you're monitoring, he's doing it, you can trust your life with this student. Means he will give you the correct prescription, he'll be a safe doctor. So at the end of the thing, IMG, what do you want? You want a safe doctor to be practicing in the community. So that is why so much of inputs into your thing. So don't feel disheartened. It's a very well written one. All the key points are there. We wanted further sub details. So final word by Dr. Adiga and we go to the next.
Yes. So as the group mentioned, superscription, name, age, gender has to be there, and if it has to be written in the prescription pad of the doctor itself, because all the things are printed, because they may not understand, suppose seal if it is not proper, if it is printed it is always better. Then the diagnosis, now it is a legal document, so it has to, diagnosis should be mentioned in capital letters, and once you go to the inscription part, that is drug name should be in capital only, full name, and always you should, the student should write or the doctor should write generic, not the brand one. There are, let us not go into the details of all those things, why we have to write generic or brand. So generic name has to be written. Then as far as dose is concerned, you have to correctly write the dose. In this case it is pediatric because it is very important, it is not like 500 mg. So according to the weight, generally 20 to 40 milligram is per kg body weight, which has to be divided in 3/8 hourly. Say for example, if the baby weighs around 15 kg, is it okay sir? 5-year-old 15 kg. So if you take an average of 20 mg or 30 mg, so you calculate accordingly, it has to be equally divided in 3 doses. Again, next comes the formulation. Formulation, usually pediatric, it is always better to go for liquid formulation. Okay, so it has to be told, and also it comes as a suspension. So instruction should be mentioned for the parent. Shake well before use, otherwise the drug particles will settle in the bottom, only the content will be there on the top. So it has to be shake the bottle very well, and after giving, not shaking the baby. Okay, so and also the frequency has to be mentioned and duration has to be mentioned. Here in this case it is otitis media 5 to 7 days. Then detailed instruction to the parent here, not much detail to the child, how frequently it has to be given, when it has to be given, somebody has mentioned, so usually after food, okay. Then drug dose, duration, okay. Then instruction, and also contact number. In case you can mention one sentence, in case of any emergency, or if you want to call, in case of any adverse effect, please contact the below mentioned number, something like that. And signature has to be there, seal must be there, and if it is, why we insist the prescription to be written in the prescription pad is, it will be clearly written, the registration number will be clearly written, suppose if it is, if you won't get the seal, okay. So those are the things which has to be there in the prescription.
Okay, thank you, sir.
Thank you, sir. Thanks to Group 4. Thank you, Dr. Prabhakar, and thank you to Group 4. Now we'll move on to Group 5. Their scenario is to take a focused history from the parent of a 3-year-old kid with fever. So who will present?
Who is going to present?
The time given for the task is 5 minutes, and marks given was 5 marks, total marks. And under checklist, first the doctor has to introduce and ask and greet the parent and the kid. After that, for that 0.5 marks. And doctor has to take all details like name, age, weight of the kid and all. And after that, asking for chief complaints, we allotted 1 mark, and for history of present illness, we allotted 1 mark, and for taking past history, antenatal history, postnatal history, we allotted 1 mark, and taking developmental history and treatment history, we allotted 1 mark. And developmental history and treatment, ma'am. Drug history. Any treatment history. 5 marks.
What is all that marks you have done to
Ma'am, this is segregation of marks. If completely done, 0.5 marks, partially done, 0.25, like that. Grading.
Poorly done 0.125.
Poorly done 0.125.
Okay, thank you.
Okay.
From this, we go to this group. You can
Yeah.
comments. Quickly. Comments, please. Constructive criticism, and then we'll go to the next group. Nothing. No comments. For once, they're all keeping quiet. Okay, next group.
What type of fever is going to
No, that is, they have to take the history, no, sir. So we have not specified what is the cause of fever, but in general, they have to take history. of fever. What is that you have written that sentence, sir?
So many things have put in some single question, ma'am.
Present illness, we'll cover all those questions, sir. Okay, sir has got a point there. He wants to know exactly how will you find out what kind of fever. Should have given marks for that separately. Continuous fever, intermittent, fever with children,
focus?
So many questions in a single question, ma'am. So many histories they have given a single mark so that they can divide. More focused. Yes, ma'am.
Illness should include more marks when compared to weightage.
Okay.
Weightage.
So she says history of presenting illness should carry more marks than
Chief complaint.
You're given equal marks.
Equal marks for HO, PA and C.
Very well.
Thank you.
Weightage. Mark weightage.
Okay.
He's a chief. Chief critic.
Right now.
Nothing?
We used to have, I don't know how many of you
Is it important to ask which parent? Does it carry any significance, ma'am? Mother or father doesn't matter. Huh?
Does it matter?
Yes.
It matters. Okay.
Because a kid with a fever, so.
It is my learning.
Points which I have learned and
We have not mentioned. No matter what, which parent we should give the
yeah, that's correct point.
Or no, Dr. Surekha was telling, in the history itself you can document who is the informant.
Mother knows better than the father.
See, that is subjective, so.
Okay, most of the times the mother knows better about the child and the father is coming from a gentleman, not from a lady. So we take it. Thank you. Thanks for the compliment. Shravana Deepti has one comment before I tell a small story. Quickly come.
Rather than taking antenatal history and postnatal history, they can be concentrating on immunization.
I was about to say that. Thanks. Yeah. I think immunization history is something that you have left. Developmental is important, but for fever, we will look at immunization more than development. Both are important, but immunization should have been mentioned. Yes. No, absolutely, but developmental also you should put, immunization should come before developmental is our take. You may be right, but immunization has to be taken. No, I was just telling a small story about the chief critic, no? Carnatic music, I don't know how many of you follow. Anyway, in Chennai, we have the music season in December. Okay, so for every new performer or even a seasoned performer as M. Subbulakshmi used to dread one critic. Anybody knows his name? He's no more. He's a fantastic critic. His name is Mr. Subbudu. If Subbudu is in the audience, everybody will get tremors automatically because he will just slice it very, what do you call? In a very scientific manner, he will split it and comment. So this is Mr. Subbudu for us in the first batch. No. Somebody has to be there to criticize, and it's a constructive criticism. He will never use any demeaning words or anything, but he will criticize the music so much that there is so much learning out of it. So thanks.
I'll close and give it to you.
You close, yeah. No, not yet. I'll get it. You have to get it. I'll get it, yeah. Thank you very much. With this, I finish my session. There are 3 takeaways. Like we have all been learning, you learn when you teach. I learned 3 points to modify 2 questions. Suturing a clean-cut wound on a mannequin or on a live person. That we have to do. And somebody said, parent. So mother or father could have been mentioned. And a grossly mixed up between hamstrings and calf muscles. Really sorry for that. Yeah.
Mini CX first. Get my laptop now.
Okay, so now I'll hand over. Madam will continue the session. Ma'am will be elaborating about DOPS and mini CX. Assessment of clinical skills. Thank you, ma'am.
Thank you. So how many of you have heard about mini CX, that is CEX? Anybody has heard? Sir was telling, so what is it? Sorry, Gautam?
The only CX video was where we exchange games. It's called Complete Entertainment Exchange. It's a game store.
Oh, that is, I'm not talking about that. Okay, anyway, thank you for that. Okay. So mini CX is mini only, means it's a short clinical evaluation exercise. Okay. My laptop, the HP illappa in the Dell. Where is my laptop? It's charging somewhere. Okay, so we are just distributing the mini CX checklist. Now we are going to request 3 of our participants to do the role play of a mini CX. Mini CX is actually used for any aspect of your clinical evaluation. It can be history taking, it can be examination, it can be explaining the diagnosis, it can be getting consent or telling the treatment part of it. So that has got various components in it. So today, because we don't have an actual patient from GH who can be examined, we have requested your own participants to, one person will be the patient, another person will be the PG taking history, third person will be the associate professor or professor evaluating the student. As the teacher is evaluating, I want you all to evaluate the student also. Okay? So, we have Dr. Afreen as the postgraduate teacher, Dr. Anil as the postgraduate student, and who was the patient? Dr. Ashwin Meno, he's Oscar Award winner. He is going to be the patient giving the history. Yeah, can we have the table and chair, pa? So just this is history taking. The PG is asked to take history from this patient for I think abdominal pain, right? Anil? Pain abdomen dane? So just, so in that form, can I have a form please? Yeah, thanks. Okay, no, Gautam, you keep it, I want you to look at it. Okay, so here this form says, you have to fill all this: trainee name, date of assessment, advanced training year. So PG, this is used for PG, but you can use for UG, maybe final years, and interns if you want to assess, maybe final years. So assessor's name, training year, which case number for that year, means which is the number of already 3 or 4 cases you have assessed the student. This is the 4th case you are assessing the student. Assessor's name, position, then whether it's an inpatient, outpatient, emergency or other. So this is an outpatient clinic. This patient has come with pain abdomen and the PG is asked to elicit history in front of the assessor. Yesterday we said no, we give a case, we go somewhere else and we don't know what history they have taken. So it is in front of the assessor. What is the patient problem, everything you should enter. And then you have this checklist for different things. Medical interviewing skills, that is what you have to rate, that is the history taking. Physical examination skills, professional qualities, communication, you can mark that also because its student is going to communicate with the patient. Counseling skills, clinical judgment, organization and efficiency. So you can choose to have a mini CX exercise for any one of these individually, or if you have the time for the entire, all the aspects of the student. So it depends on how much time you are allotting for this. If it's in a very busy OP, you can do a 1-minute preceptor, but it's going to be in the ward, you can even give half an hour, so you can be, so whatever you are examining only you should mark, you should not mark all the aspects. Here we are going to do only the medical interviewing skills, maybe the communication skills we are going to assess. So please mark this student and we'll give the overall, grading is not observed, superior, satisfactory and unsatisfactory. Numbering is given 1 to 9. You have to circle the appropriate number. If that skill has not been observed, please tick it as not observed. Is it clear? Anybody has got any doubt about the form as our actors are gearing up for the show? No? Okay. And then in this, most important you notice below is not only the teacher is signing, the trainee is also signing saying he is satisfied with the way he has been examined. If he is not satisfied, if he thinks the teacher is biased, he's got every right not to sign this paper, and this paper goes into the student's portfolio. That is a PG's portfolio. UG's we don't maintain a portfolio, but at least you can keep the marks or whatever as. This you can use classically for the clinicians, the ward leaving test. If you want to do a ward leaving test, at the end of the posting test, ward leaving test, mini CX can be used for undergraduate students. Okay? So, okay, time up, you have to start. You can, I will just give the, you need form, Rika. Do we have an extra form? Can you give the form to Afreen, please? So at the end of it, Dr. Afreen will say how she has rated the student, and you can agree or disagree with her, but I want everybody to rate the student. Whose form? Thank you. Rate the PG, not the patient or the teacher. Because I'm sure the patient is going to act much better than the other two. So let's see.
Mic is yours. Thanks.
So we'll be sitting in OP and we'll make the patient to lie down once he comes. Oh, no examination. Okay.
Proceed with the examination.
Please come. You wait. You sit.
Hello.
Hello, Mr. Mukesh.
Good morning. What's your name?
My name is Rajesh, sir.
Okay, you are coming from which
I'm
place?
coming from Chittoor only, sir.
Chittoor only. So, what
I
happened?
have severe abdomen pain, sir, since 3 days.
Since 3 days.
I'm not able to eat anything, sir.
Okay.
And it's paining a lot, sir.
In how many days you are getting pain?
Sir, for past 3 days, sir.
3 days. Whether it's getting in the lower abdomen or in the upper side?
Don't know, sir. Somewhere here only, the region only.
Okay. Along with the pain, have you got any nausea feeling?
Yes, sir. I got like vomiting sensation. You are asking, no, sir.
Okay.
Yes, sir. Vomiting like I'm getting, sir.
Okay. So these past 3 days, you have any decreased appetite?
Yes, sir. I'm not eating properly, sir.
Okay.
Everything, food also getting waste in home, sir.
Okay. Do you have any similar complaints in the past?
No, sir. Nothing like that,
Nothing. This is
sir.
the
I
first
eat
time you are
nicely.
getting the pain.
Yes, sir. I eat nicely, sir.
Okay. What you will do?
Always eat outside food only, sir.
Okay. Okay. Do you have any symptoms of TB in the past?
No, sir. No TB and all, sir.
No TB at
No
all.
TB.
Okay, fine. Shall we examine?
Okay.
We'll examine once.
Okay, sir.
Then we'll let you know what is going on.
Sure, sir.
Okay?
Sure. Okay.
Are you okay with the examination?
Sure, sir.
Yeah, yeah. Do the same.
Please come. Leave your chair. You can leave your
Get
chair
there.
here.
Here.
తల ఎంత పక్కన పెట్టుకో.
Okay, na? You can come down. You can come down. You just fold your legs. Okay, sir. Okay. So be cool. Okay. Nothing will be there. Okay. What is happening?
Pain, sir.
Okay, get there. Yeah, there is any pain?
No, sir. No, sir.
Huh?
No pain. No.
Okay.
I think he's having.
Yeah, ma'am. He is having some acute abdomen, so maybe it is looking like acute appendicitis. So,
Why do you think so?
because the onset of pain is since 3 days. Along with it is a nausea, vomiting are there, and there is a loss of appetite also.
Okay.
So it is.
Mic దగ్గర.
So the pain abdomen is since from 3 days acute attack. So it is more in the RAF pain, along with nausea, vomiting, loss of appetite. It's there. It's more towards in terms of chronic long histories. Duration is not there regarding the tuberculosis or regarding the malignancy. There is no loss of appetite, weight, or any melena. So that's why I'm suspecting it is appendicitis. Then we'll confirm it with the ultrasound abdomen. Then we'll proceed accordingly, ma'am.
So what are you going to do with this patient now?
Now I will send for ultrasound abdomen and pelvis to rule out regarding any inflammation in the appendicitis, any periappendicular fat stranding, the size of the diameter of the appendix. So after that we'll see. First we'll send for scan. So after scan, so it's looking like a surgical emergency. So nothing to worry about that. So first we'll do a scan. Later on we'll tell what we'll do. Okay? Okay, we'll write on scan, then go for a scan and get back.
Okay, sir. Thank you, sir.
Feedback. I should make it. So what is that form? So regarding history taking, I think he has taken a good history taking. He has taken all negative histories also. So even the clinical judgment was correct. Should I have to mark him, ma'am?
Just tell your marks, then we'll ask each group.
Okay.
So okay, I will. You tell me what is a mark for medical interview.
So for medical interviewing skills, Dr. Afreen is going to rate the student as 8 out of 9. Okay? 8 superior for the history taking, medical interviewing skills. We'll just keep the marks, just keep it in mind. Anybody agrees or disagrees, I will ask you later. Physical examination skills, Dr. Afreen?
Yes, ma'am, it is 9.
9. Oh, very nice teacher. Okay. Then anything else you have? Communication skills?
Okay, ma'am, 9 again.
9 again. Counseling skills?
9 again.
9. Clinical judgment? 9. Okay. Organization and efficiency, you want to comment?
No, okay. So she says she doesn't, she has not really assessed in the form of looking at his organization efficiency, but we will leave that. So, madam has given medical interviewing skills is 8, physical examination skills is 9, communication is 9, counseling skills is 9, clinical judgment is 9. Okay, before we go into the group discussion, big round of applause for all 3 of them. Thank you.
Thank you, ma'am.
Thank you so much. We have just given them 10 minutes or even 5 minutes notice to get ready with the role play. I think they have done a wonderful job. Now we'll start with this. Thank you. You can go back to your groups. Thank you so much. We'll ask this group whether you agree with Dr. Afreen's judgment or anybody wants to differ. Karthik.
In the history, they didn't ask for he's passing any it's in history of constipation or
So you don't want to give 8, you want to give 6. 7 is okay. He's a very nice teacher. Okay, most important, anybody with abdominal pain, you have to ask about bowel movements. Maybe Anil didn't ask exactly for constipation or obstipation. So he says, I will not rate him 8, I will rate him 7. Still superior. Okay. I will say 6. Okay. Anything else you differ from what Dr. Afreen has judged? Yes, this group? Because Anil is there, you feel very bad, huh? Don't worry.
Ma'am, sir is using all medical terminology while interviewing patients, appetite, nausea, something.
No. Okay, educated. He says he knows all the English words. They have Google searched everything before they came to me, so they must be knowing. Yeah, but madam has got a point. You have to use non-medical terms as far as possible when you are talking. Here we are talking in English, but I'm sure when you have seen patients, you're going to talk in their local language. Yeah, point well taken. So counseling, how many marks, what is your rating then?
7, ma'am.
7.
Except that and remaining
everything. Okay, 7. Okay, not 9 but 7. Okay, great. Anything else? Okay, we'll go to the next group.
Physical examination, I will give only 6, madam.
Why, sir?
Mike,
sir.
He has not done inspection, palpation, routine wise in physical examination.
Okay, he did a brief.
Pulse also he has not mentioned.
Pulse also he has not mentioned. Tachycardia, patient is in shock. Is it a perforated DU?
Just 1 second, ma'am. I have examined the pulse on the on-table.
You didn't mention the pulse rate. Okay. So he is examined, but he didn't?
Temperature also.
He didn't mention the pulse rates? No, but did he tell you what is the pulse rate? He didn't. So that is a point sir is making. Valid point. So sir says he will give only 6. He's still in the satisfactory. So it's always important. Why you got 6, you have to explain to the student and they have to
temperature
make up for the next clinical case presentation. They should be able to remember that point. Anything else?
Counseling of patient. Sir directly told about the surgery, so I
told about the surgery. I just told initially scan, after that we'll proceed, then according to the BCME scan.
Okay.
Surgical.
So
that's what I told with the
So what he said is surgical emergency, but it's good to say I'm suspecting a surgical emergency. We'll do a scan. Once a scan comes, blood test comes, we will tell you whether surgery is done or not. So you have to break it slowly. That's what he's tried to do. But sometimes when you say surgery itself, patient's BP will go down or go up. So that is true. But we have to tell the truth. No, we can't be. Some patients come and tell, don't tell my mother that she has cancer. But when I give her chemotherapy, all her hair will fall and she will feel weak. How do I explain why I'm giving strong drugs? So it's better to explain, but break it in pieces. Okay, your point is well taken. Okay, anybody else? Nothing? Babita is scared to criticize you, Anil. What is this? She doesn't want to say anything. Anything? Okay, so we largely agree the student is satisfactory and above, so almost to the point of being superior. So that is the way you should, and you should discuss this feedback with the student and get the student signature as well as you have to take the signature. Thank you very much for your very active participation. We go to the fag end of the next 5 minutes. Vijay? Is a speaker connected? If I play a video, voice varuma? Idu vechukko. Can you distribute the next set of forms, please? Jyoti? Next set of forms.
So the next last part of this assessment of skills is DOPS. So what is DOPS? Directly observed procedural skills. Okay, so this is evaluation of procedural skills. This is actually done on patients. So this will be useful for interns and postgraduates, not maybe our undergraduate students. But some people, instead of using OSCE, they use this DOPS in simulation lab also, but it's not correct. The procedure should be done on actual patients, so it is for interns and postgraduates. So we are just distributing the DOPS checklist form. Okay, this is done by one of the Royal Colleges, I think Ireland or Australia, I'm not sure, for any surgical skill. It is very, very generic and very broad. Okay, and then you have whether the rating is there for the skill, and there is something called global rating. So basically they use it for postgraduates, they don't use it for house officers or interns. Okay, so that is a form that I have shared. I will just project the form first here. Form first. Okay, first form தான்ப்பா, வீடியோ இல்லை. இதை க்ளோஸ் பண்ண சரி பார்க்கலாம். We'll see if it doesn't come also, it doesn't matter. So this is the form that I have given you. Okay, so if you see that again, it is the whatever the number of the student trainee number, assessment date, where the hospital took place, and then this is the feedback. Verbal and written feedback is a mandatory component of this assessment. We'll come to the feedback later. We'll go down to and then the trainee's reflection should also be documented. The ratings. Okay, again the letters are, if you have not observed, you have to write N. Development required, that means D. S is satisfactory. That is, the student did not require any prompting or any intervention. O is outstanding. Okay. So, if you take any surgical procedure, describes indications, anatomy, procedure and complications to assessor, obtains consent, prepares for procedure, it's almost like the suturing skill that you guys have done. But it is more global assessment, demonstrates good asepsis, performs the technical aspects in line, deals with any unexpected event or seeks help when appropriate, completes required documentation written or dictated, communicates clearly with the patient and the staff throughout the procedure, demonstrates professional behavior throughout the procedure. So you have to rate, and if you are rating something unsatisfactory, you have to give your comment as to why you made that rating also. And then there is something called global summary. So it goes from level 0 to level 4B. Level 0 is insufficient evidence. In one episode, you don't want to pass judgment on the student. You want to assess the student again. And then there are different levels of global summary. Again, everything, all these things, whether it's done in elective setting, emergency setting, how many times the student has actually done this procedure before you assess. That's also important. And the ease of the procedure, is it difficult, more difficult than usual. And then again here you take the training signature and the SSR signature. So much of detail is there. Most people use it for postgraduate evaluation. It can be procedure, same thing you can adopt it for non-surgical procedure. For pediatrics, maybe doing an LP or doing an ascitic tap in general medicine. Whichever postgraduate department is there, you can adopt it appropriately. So this is the DOPS form. I'll try to show a video, hopefully it opens. Of a small surgical procedure that one of my postgraduates had done in the previous institute, and I had given I marked him on the DOPS and given a feedback to him. I think the video is about 14 minutes. I will run through it, so don't worry. This is my previous institute. So this is basically, this was COVID time, so you can see all the double mask and all that, all of us, at least I am in a scrub suit. This is just a outpatient incision and drainage of a paronychia. Very simple procedure. This is my first year PG who is doing it. He has done it at least 2 or 3 times before, and I am assessing him. So you just watch all the steps. The audio is not coming, it's okay. You have to rate him according to the form that I have given. Then volume marla. Oh, na the volume low பண்ணிருக்கேன். Okay.
Full ஆயிடு.
Okay, the audio is not coming, doesn't matter, it's better the audio is not there, you just check the steps. Light, we can't switch off, can we switch off this light? Vasant, somebody can switch off this row of lights? No, huh? Sorry, there's some technical glitch, we'll just, varleyappa. Idella off. Can you see little better? Sorry, we can't. There is some problem, we are not able to switch off these lights. This is taken with a cell phone camera, so you will see suddenly the head coming in the way. Can't help it. Huh? Seri paravailla vittudu. It's okay.
Close பண்ணி on.
Just run through it, huh? Because it takes more than. So we'll assume the student has explained to the patient, I'm going to give a injection now, it will hurt a little bit, then it will become insensate. He has explained it, I know that. Unfortunately, I'm not getting the audio on. Okay, he says we'll close it once and try it again, so let me do that. Sorry. Till now you observe and mark the student.
ஓபன் பண்ணிட்டா நீ பண்ணு, நீ என்ன பண்ணுமா பண்ணு. இன்டர்நெட் வேணுமா? இல்லையே.
Okay, you have to check that before you start loading. Date of expiry, particulate matter. Now you can load, please.
August.
Okay.
So you can see the paranoia there with lot of pus around that. This is what happens. Phone rings as you're operating.
Wait for some more time. Actually, what you have to tell her is, touch sensation will be there, pain will be there. माँ सुन तो बेटा, दर्द है? हाँ, okay, ठीक है, दर्द है, okay.
I think the patient is passed out, she's not responding only. Physicians, be ready for BLS for your co-participants. You don't want to see
You did the case yesterday.
Yes.
So I want you to tell me, reflect and tell me how well you did the procedure yesterday.
It's not immediately because I'm in a different dress. It's a next day morning, okay? It's not immediately, whatever little feedback I gave him in the bedside, but this is next day, this is a formal debriefing where I have the form with me. I'll go through each point and I'll mark, I'll discuss and find out what he has to say, okay? So do you think I intervened at all in this procedure? Did I intervene at any time? It's a very small procedure, but I did say he was planning to take the knife and nick when the patient was not clearly saying whether it's still paining or not. So I told him to wait, give some more local, then proceed. So this is the meaning of directly observed procedural skills. If they make a mistake or something, we are there to correct them and tell them that this is what you have to do or you have to wait for some more time. So I am giving a debrief, will not
I was little unhappy because your phone kept ringing throughout and you had to tell the sister, but you told the sister that you to switch it off and you didn't attend to the phone call. That is very important because
see, the phone should be switched off, so I'm not giving full marks for him because that caused disturbance. Your phone should be in silent mode or hand over the phone to somebody else when you are doing any surgery.
Definitely satisfactory in view and outstanding in couple of these steps that we described. The global summary I'm supposed to give, which is, so I would say level 4A, procedure performed confidently to rise.
So I've given level 4A as a global summary. Okay.
Intervention and this everything I said satisfactory except for the local anesthesia part.
Yeah, except for the local anesthesia part, I've given satisfactory, okay, for most of the other steps. So that's it. And then we give the feedback and take the students' concurrence and
how many times before? So you sign here.
So I make the student also sign and then one copy goes with him and one copy I keep it in the office. Okay, so the tips for doing DOPS is the student can choose which teacher can assess them. They can choose their favorite assistant professor, but they can't choose the same assistant professor every time because the rating will be favorable. So it has to be rotated through all levels of teachers, and the HOD has got the final call as to how many times he has to undergo, how many people can assess that student on various skills, and this is done in a periodic manner. You find that the learning of the skill is better and they are more confident when they actually go out and do even small surgeries like this. So that is the advantage of DOPS. It can be, as I said, extended to any non-surgical procedure in your own specialty, and if you do it very diligently, the student understands the criticism is meant for his growth and not as a means of some personal comments. So you have to make it as objective as possible and give appropriate explanation for the low scoring or the high scoring. So this is done in the first year of residency. They say at least 3 or 4 times in all the basic skills as first year. Second year they go again 3 or 4 times, all by different assessors, and then the grade point average is done in the final year, and then they take a call whether this guy has to have more practice in the skill or not. Maybe they'll go and do it in the simulation lab and come back on the patient again. So this is how it is very useful. So I hope anybody has got any doubts or any comments, I'll invite that before we close the session. Yes? Anything?
Disconnect பண்ணு.
Any comments? Yes, Anil, you want to ask something? Sir wants to have the final word as usual. Yes, Gautam. You want to say something? Please.
Amy.
the anesthesia was not mentioned if it was adrenaline, non-adrenaline. The draping technique was bad. The local application was not in the figure of 4. So.
Local anesthesia, what was the point, Thambi?
Without adrenaline.
What do you expect in a finger? What do you expect? You saw the bottle, no? The bottle, what was the color? What was the color of the bottle? It's white and blue. That means it is without adrenaline. If it has got a red band, it is adrenaline. See, here he is not, okay, I take your point. The student has to check and see whether it is with adrenaline, without adrenaline. Very important, because these are all end arteries in a finger. If I give with adrenaline, it leads to gangrene. Important point, yes. But here
Communicate before giving LA saying that he's got administered.
yeah, that I ran over that. That is true. I fast forward it, we missed that. He did say that he didn't know Hindi, so I said, you don't know Hindi, huh? I said, abhi sui dalna hai, dard hoga. I said that. Okay, so I talked instead of the PG because his Hindi command is not good and the patient is a North Indian patient. Yeah, but patient, you have to tell the patient that I am going to give the local anesthesia, it will pain and then after that it will become insensate. Correct, point taken. Yes, next. Okay, so this is an outpatient procedure. Yes, point taken. You should cover the rest of the area with a sterile towel. Only the area to be operated should be exposed. Correct, absolutely. So what is your rating then? You tell me the rating and you have to explain why you gave a lower rating. You give, huh? 3B. So I have given 4A. Maybe I like the PG very much, but I don't. But okay, I take your point. Yes, so he will give only 3B and not 4A as in the global summary. Okay, anything else? You should not recap the needle. Very important. Excellent. Thank you for bringing that. How do you recap needles? You put it on a surface and recap. You don't hold on your hand and recap. Absolutely correct. So actually my judgment is a little biased. So I should maybe give only 3B as Anil said. Yes, very nice. Thank you for that. Anything else? That's why I told him wait. That's why I rated him low, because he was in a hurry to put the knife without checking properly. In fact, I made him give more local anesthesia because patient still had pain. After that only I allowed him to put the knife. Correct, absolutely correct. All of us do that, right? More so PGs, we also do that. Test dose already given, sir. That is not part of it. Consent already taken. Yeah, test dose has to be given, consent has to be taken. Yeah. Okay. Thank you so much for actively watching the video and giving your comment, and thanks a lot. I'll ask Ramya to conclude this. I'll conclude the session. Okay, thank you so much. We come to the end of the skills assessment session. Now over to Dr. Kishore. Pre-lung session. It's going to be very easy on you. Okay? Just sit back and relax.
Yeah,
before lunch is my last session. This is regarding completely a different thing that what we are going on across the things that we are on sequence. Okay, so before lunch we will be doing some important thing that we need to have while we are in the field of medicine. Like one need to know about academic growth, especially academic growth in medical education, and also networking in medical education. So at the end of this session, the participants will be able to understand how the evolution of the medical education in India was, like history of medical education in India, what are the avenues or the pathways for the growth in medical education, the role of medical education units, and the role of members in the medical education unit, the opportunities for the further courses in medical education, and also finally the networking in medical education. So if you look back into the history of medical education, so you can grossly divide this into 4 different eras. Okay, grossly into 4 different eras. One as an ancient and classical period, another as a colonial era, where the introduction of the Western medicine has come into in India, and post-independence era, like a post-independence expansion and reformations that had happened in the medicine in India, and also lastly the 20th to 21st century modernization and medical education technologies that have come across. So ancient and classical period, if you look into, like we know the father of medicine like Charaka and Charaka Samhita and Sushruta Samhita, where these are the things where mainly into the medicine and also into the surgery which have evolved, and Ayurveda was the oldest organized medical science in the world that has been more predominantly looked into in Indian medicine. So if you look back or look into 1600 to 200 BCE, foundational texts like Charaka Samhita and Sushruta Samhita, which provided highly structured curricula to understand, and the Gurukula system, a residential form of learning, student lived with and learned directly, they had what kind of like training spanned several years and involved observation, hands-on practices, memorization of slokas, and ethical instructions and community service. All these were being done in the good old that now we are going to have a small group teaching kind of things and hands-on practices, all these which we are now parallelly planning to follow. Sushruta Samhita is a landmark in global medical history, where Sushruta was being regarded as the father of surgery, described in meticulous detailed various operative procedures, including rhinoplasty, cataract extractions, lithotomy, like wound suturing and fracture management. Battery level Vijay. Change. He also emphasized that importance of simulation-based training also, like during that period only, used models such as animal skins and also clay structures to teach incision, suturing and bandages, an approach strikingly similar to modern skills and laboratory methods. So, okay. So, to close with how the ancient and the classical era of the medical education was, so it is a multidisciplinary covering mainly the Ayurvedic education, which mainly looked into anatomy, physiology, pharmacology as Dravyagna, toxicology as Aganda Tantra, and obstetrics, pediatrics, psychiatry, ethics, and what you call dietetics. These systems remained dominant for centuries in India, and continue to influence the Indian healthcare, which also nowadays we are even seeing things like Ayurvedic systems that are being followed. So later, after a period, there was an Unani medicine with the arrival of Persian and Arab scholars during the Delhi Sultanate and Mughal periods. The Unani medicine also became another prominent system of healthcare system. Principles from Hippocrates and Galen also has been taken into, blended with the Indian method of medicine, and both put together looked as an Unani medicine. By the medieval period, we had both Indian and also the parallel systems of structured medical training, especially both the Ayurveda and also the Unani medicines, each with its own theoretical foundations and also a pedagogical approach to understand the medical education for the students that are being taught. Next came the colonial era, where the most transformative phase in medical education began during the British colonial rule, when the Western allopathic medicine was being introduced systematically. So establishment of native medical institutions was the thing that started during the period, especially in Kolkata, which now we call it as Kolkata in 1822. European and Indian systems both were being taught during this period. However, this hybrid model was soon replaced by a purely allopathic approach. So, do you all know when first medical college, or when and where the first medical college? Probably might be knowing where, but when the first medical college has been started in India? 1800s, good. It is in 1835, the medical college with hospital was started in Calcutta, and in the same year the Madras Medical College was started, and in 1845 the Grand Medical College in Mumbai was started, and it was during this period where these medical colleges have been established at these three different places. They introduced a standard curriculum emphasizing mainly on anatomy through cadaver dissection, physiology, pathology, pharmacy, and also hospital-based clinical practices or clinical rotations. So during this period, curricular and structural growth in medical education was there. That is, during 19th and 20th centuries, the British established numerous medical schools and dispensaries, especially training the subordinate staff, medical staff, and also they proposed what you call IMS, which you call it as Indian Medical Service, formalized a professional medical practice. And in 1946, a Board committee report recommended strengthening the undergraduate education, emphasizing on preventive medicine, integration of services to what you call the primary level, secondary level, and also the tertiary levels. So these things, report has been given in 1946, and later where the regulation or the formation of Medical Council of India has come into during this period. Especially a landmark reform was the Medical Council of India, established under the Indian Medical Council Act in 1933. Okay, so the MCI, that is the Medical Council of India, standardized medical curricula, ensured the quality of training institutions, regulated professional conduct, and granted recognition to medical colleges. They started recognizing various medical colleges, started recognizing them, and this was India's first formal regulatory body for medical education, and this was the logo especially for the Medical Council of India. So later, the post-independence, that is 1947, the post-independence expansion and reformations. After the independence in 1947, India faced enormous public health problems and public health challenges, and need for rapid expansion of medical colleges was prompted, and the central and state governments invested heavily in establishing new institutions, including the first All India Institute of Medical Sciences in 1956, which became a model of excellence. And the growth of undergraduate and postgraduate education has developed. The MBBS program evolved into more structured format with preclinical, paraclinical and clinical phases as 3 different phases. And postgraduate education, especially with MD, MS and diploma courses, expanded significantly from 1960s to 1990s, producing specialists in various fields. Increase in private medical colleges from the 1980s started onwards, broadened access, but it has certain concerns, like raised concerns were there with the private medical colleges coming up regarding the transparency, fees and quality, leading to continuous evaluation of certain reforms that are being made as a regulatory networking or regulatory frameworks. So late 20th to early 21st centuries, by the 2000s, medical education in India witnessed major challenges influenced by the global trends. Like we have seen 2019 where the new CBME curriculum has started, and it was due to one of the challenges that has come from the globally that has come. Because of that, the change of the curriculum has been introduced. This change of curriculum has been introduced into India. The key developments included, especially during this period, the medical education units were established in medical colleges to train the faculty, promote the pedagogical innovation, and also support the curricular reforms. And a course called as an advanced course in medical education, an initiative which strengthened the leadership in health professional education, especially mainly focusing on the curriculum design, curriculum that is assessment, and also the educational research also. So simulations and skill laboratories, skill labs were introduced to enhance the patient's safe learning through mannequins, models and also simulated scenarios, an approach already envisioned by Shushrutan during that period. The same kind of approach was there. Curriculum reforms, the need for an outcome-based curriculum, especially which you call it as now the curriculum-based medical education, mainly the CBME, led to the introduction of integrated teaching, early clinical exposures, OSCE assessment, mainly the student-centric kind of thing that has been approached into. So approximately in 2020, where the MCI has where it transformed into NMC, which you call it as National Medical Commission, where in between where the Board of Governors were there, those who are looking into this. National Medical Commission has come in existence from 2020. In 2020, the Medical Council of India has been replaced by the National Medical Commission, marking one of the most significant reforms in medical education. And introduction of this started from 2019, where 2019 the CBME program has started, focusing mainly on various defined competencies, early clinical exposure, foundation course, electives, ATCOM, that is attitude, ethics and communication, and also the formative assessments. And we are still in search or getting into the approvals for the next examination, which also is a proposal from the NMC. The next serves as a common licensure exam, a final MBBS examination pattern, and also a PG entrance test. The same will be, both will be as what you call the final licensure examination for MBBS. In the same way, it will be a pathway for the PG entrance examination, aiming to standardize the outcomes. So regulation and standardization of NMC. NMC introduced a clear guidelines. It has a very much clear guidelines regarding the minimum standard requirements for a medical college. So not even the government medical colleges and also the private medical colleges, both should have a standard, like they should follow these particular minimum standard guidelines for medical education. The teacher-student ratio should be maintained, and a faculty development should be continuously going on. Skill labs and simulation facilities should be available, and a transparent accreditation mechanism should be followed. So if you look into the growth metrics of how the colleges or the medical colleges are being there in India. So 1971 to 72, it's not clear much, but there were about 98 medical colleges. And in 2020s to 21, it was something around, this was the old stats, 595. And if you look into the ratio of the same with the government and private medical colleges, you have a more number of private medical colleges increasing overall, but something around 2021, almost a parallel of both government and private medical colleges were there. So 61% more medical seats in about 5 years growth was there from 2017 to 2024. And if you see, the total medical colleges increased about 102% from 318 in 2014. So total number of medical colleges in 2014 were 318, where in update in today's date, the total medical colleges in India are 820. Okay. And MBBS seats, if you look into the undergraduates, those who come out after each year, increased by around 130% from 51,548 before 2014, where now by 2025 onwards, so this year's admission onwards, if you see 5 years after, so 1,28,975 students come up. So postgraduate students increased to 138% from 31,185 before 2014 to 82,000 as of 2025. And if you look into the India's metrics of growth metrics and India's metrics of doctor population ratio, the WHO standard is something around 1:1,000, where now we are the estimated doctor population ratio in India is 1:811, and we have already achieved it. Actually, to be frank, no further medical colleges are not required in India. Okay. So this is a picture showing where a government, and this is a 2023-24 stats, where the government across the states, how many are there? If you look into AP, there were in 2023-24, 13 government and 19 private medical colleges were there. And in Telangana, it is 19 and 27 medical colleges are there. And the same thing as of 2025, 820 medical colleges all over India, and 1,28,975 Indian medical graduates come out each year. And if you look into the, based on these stats, if you look into the avenues of the medical education, mainly the courses that are being looked into are where you get out the MBBS students and also MD, MS and DNB students. This is one avenue where you produce the pathway you give to these kind of category of students every year with the CBME curriculum. You make them to understand the clinical skills, the professionalism and also the patient-centered care here for them. And also there is an avenue for medical education technology, which you call it as MET, where there are various ways by which you can learn about the medical education technology. One is by diploma in medical education, another is by fellowship in medical education, and masters in health professional education systems. Okay, these are the three, and where all these three systems have a collaboration with the national and also the international universities, and all these follow to have programs which prepare the faculty especially to design the curricula and also to implement good or innovative teaching learning methodologies, which also help to reform the educational system. Another avenue is research in health professional education, mainly by learning outcomes, assessment methods, simulation-based education, faculty development, which can help to have a good quality and quantitative researches that can be done. So one is to prepare MBBS, MD, MS or otherwise DM, MCH candidates every year. Parallelly, you have like a medical education technologies by which you can improve the standard curricula, and the third one is by research. Okay, research in health professional education where it helps out to have a good quality in qualitative and quantitative research. The fourth one is by simulation and skill training, especially by skill labs, the virtual reality based training, and also by having standardized patients, through which opportunities for educators, simulation technologies, and also the curriculum developers can be made into. If you look into the role, especially of the medical education unit, there is a flow chart by which you can have a look. The then previous medical education, that is Medical Council of India, now which has been into the National Medical Commission. As a part of graduate medical education in 1997, it started establishing what you call the medical education units in all the medical colleges. And these medical colleges to have the medical education unit, so it also had nodal centers all over the India. And the nodal centers, if you look into the nodal centers all over the India, it is like there are 10 nodal centers all over India, which mainly concentrate on medical education units. The Christian Medical College Ludhiana, Jawaharlal Nehru Medical College Wardha, and NHL Municipal College Ahmedabad, Ramchandra Medical College and Research Institute Chennai, John's Medical College Bengaluru, and GS Medical College, Seth GS Medical College and KEM Medical College Mumbai, Government Medical College Kottayam, and Pramukh Swami Medical College Karamsad, Christian Medical College Velur, and Jawaharlal Medical College in Belgaum. So these are the 10 nodal centers that are available all over India that train the medical faculty and then help out to evolve or generate the medical trained especially with the reform. So nodal centers have their regional centers, so we also have regional centers, and these regional centers help out all the medical colleges to involve. That means, so one nodal center will have a few regional centers, and the few regional centers will be taking out many medical colleges in and around. We are tied up with the CMC Velur Nodal Center. So the same thing happens to each and every medical college. They should have a tie-up to have the education program or the faculty development programs that happen. So medical education technologies was the first initial thing that was used to train the medical fraternity, and it was changed to medical course workshops. And later there was a revised thing that has happened, which you call it as a revised basic course workshop, which you call RBCW, and now that has been transformed into what you are undergoing the training, which you call it as basic course in medical education, BCME program. So this is the program, this is the fundamental program that is being done for all to undergo the training, so that not for promotion, but for getting trained and then train the undergraduate students. Okay, now what is the role? So each and every medical college has its medical education units, and this medical education unit will have a role, and let us understand what exactly the role of the medical education units will be in each medical college. Okay, so they have to develop faculty development programs, which you call it as FDP programs. Okay, and these programs are these should be as NMC approved programs, and focuses mainly on topics as per the need of the faculty, and also create learning resource materials. So even medical education units has to create certain learning resource materials, and also they have to do certain smaller programs which you call it as non-NMC small faculty development programs too, and should be able to support as a role for capacity building as facilitators, especially in training some of the activities that are being done regularly, like any SDL program or any aligned and integration programs, or otherwise any electives that are being happening in the institute. So the faculty can approach the medical education facilitators that are the medical education members, and then can get suggestions so that the program can be done among the certain batch students regularly. And the medical education unit should also coordinate with the regional center. They will generally coordinate with the regional centers or otherwise the rural centers to have a plan of action and prepare and maintain reports and records of the proceedings that are happening in that particular institute and send a quarterly report to the nodal center, which will be monitored by National Medical Commission, mainly the Academic Council of the National Medical Commission. So apart from this BCME course that we are going through, there are some other courses that can be learned out of interest. One is advanced course in medical education, and this is an ACME program. This is a 6 months program that happens. I think probably yesterday you might have seen two people sitting, and day before yesterday one person sitting there. So they are actually in ACME program. Okay, so it is a 6 months program, and they will have 1 day session where they need to attend any BCME course that happens all over, and they should give a report of the entire program, how it happened, what happened, and what they have learned from the program. Okay, so it is a process and of 6 months continuous program, and previously it was about 1 year program. So when we did it, it was about a 1 year program, and it will have 2 contact sessions. So it is not continuous being there. It will have 2 contact sessions of 5 days each, and the other thing will be like an online session. So you will be having a group task that will be given. You will be formulated into groups, and you should be regularly giving mails or through whatever the contact. So you will be in contact online. You will be in contact, and that has been reduced to 6 months now. And I think it's very easy, and you need to do a small project. Okay, you need to do a small project within these 6 months. There is another program called as FAMER, Foundation for Advancement of International Medical Education and Research. Okay, so FAMER fellowship program, this is a 2-year program that is being done, and this is an international program actually, international across the countries and regional. In India, this program is being done at 2 places. One is at CMC Ludhiana, and another is at PSG Institute of Medical Sciences, Coimbatore. These are the 2 most of the important programs that are being done for medical education. Safe Grant. Okay. Sorry for that. Actually, thank you, madam, for enlightening. And lastly, I just want to close with this networking. And what do you mean by networking? So are we using any methods for networking? WhatsApp group, good. Any other networking things that we do? Telegram, mails, conferences. So other than that, first WhatsApp came, madam. Workshops, good. BCME program. Yes, good. Associations. So each, probably if you see in our medical education, we see each department has their own associations where they have a networking kind of thing. Okay, good. So Robert Kiyosaki, he said about what networking is. So the richest people in the world look for and build networks. Okay, so everyone else look for working. Okay, so this why I am telling is networking is such important, not only to become rich but also to have communications between people and learn new things. Okay, so networking defines, like, it refers to the art of creating interdependent or interconnected groups or systems for a mutual benefit. So wherever you look for a networking, you need to have a mutual benefit of all the members of the particular system. So networking can have relationships, career, opportunities, contacts, through internet, you can have an access, business cards, colleagues, so all these will help out. All these things will help out to have, and you can have a success, have good communities, meet and greet, and some common interest people generally have that particular network. Is there a need of networking in medical education? Yeah, definitely, right? Yes. And now, what are your experiences of networking of professional growth? Is a think, pair and share method. So what worked well? Just have a discussion among your pair and then come out with some ideas of how it helped you, what worked well in experiencing of networking in your professional growth, what were the challenges where you had while during this professional growth, what could have been done better to overcome the challenges. Just a 2 minutes or 5 minutes discussion among yourselves and come out. Each group should come out with some of the ideas, especially for networking of the professional. Another last minute. Any group is ready? Group 1? Ready, madam? Yeah, please, all of you.
Sir, the first question, what worked well? In terms of easy accessibility, network is helping, and for proper information and knowledge, and for effective communication, and also for having a interaction among the faculty students or in multiple aspects, it worked well. And the challenges we faced were validity is reducing, and the
News validity.
multiple sources we are getting the information, and the validity of the information is reducing. And the different and varied opinions because of multiple sources, and critics. Yes. And how to overcome means follow the standard and reliable sources.
Sources of information. Many misleading informations are coming. You mean to say in the internet or in the group only? So you have some debates where you need to challenge of certain things. Okay, good. What about group 2?
What worked well, we can have the recent advances, updates and all from the departments, and we can have integration, sharing of the resources. Everybody can't have the same resources, so sharing of the resources, that worked well. And what were the challenges? First thing, difference in opinions and peer pressure to balance work and family constraints. Those were the challenges. And what could have been done better to overcome the challenges is, myself, I felt to be a good listener than debating to overcome the challenge. And
for me as a general surgeon, we are more getting knowledge regarding conferences and by seeing any YouTube videos. And regarding challenges, it would be better if there is any direct interaction with the surgeon who teaches us better, and what could be done for overcome the challenges. For example, For example, if a pioneer in the particular surgery comes to us and teaches us, it will be better.
Good. We'll have an applause after finishing every group. About group 3?
So what worked well at the conferences and the CMEs so that recent advances can be known from them? Past experience, through conference only we'll get to know the knowledge. In the departments we'll be at departmental meetings. We'll get to know what to do and what not to do. That we can do.
Meeting old friends.
Nothing, ma'am. Just meeting old colleagues and sharing knowledge in the same field, same specialty.
Meet former colleagues and exchange information.
Challenges.
So actually exchange of ideas through panel discussions that would be held. So some different obstetricians, they come from different cities. What are they following? What are the current trends? So we will have an update of knowledge of the drugs, or how we're evaluating a patient somewhere in other states also. That actually helped. Yes, sir.
Group 4?
What worked well was active participation, sir. I volunteered conferences in my PG days, and also during workshops asking questions and solving that one. And then what were the challenges? Main challenge was that fear of approaching seniors. Then there was a lack of confidence in me and also communication skills. Then due to academic overload or workload, we were having time constraints, sir. So what could be done better to overcome the challenge was that student participation in academic activities during PG days only, sir. And then mentorship programs should be there in academic events, sir.
So when I went to Hyderabad, so I left CMC and I went to Hyderabad. So there I am jobless. I don't have any job there. So there I joined a group, WhatsApp group, AP Pediatrics in Telangana, Pediatrics group. There every day they will be posting the whatever the jobs there are, and whatever the duties are there, and conferences are there, whatever they are facing the problems, everything will be posted in that group, AP Telangana Pediatrics group. So with that, within a month I have got lot of contacts so that I can approach them. Then it became smooth for me. Yeah, before that I am scared that what I have to do in Hyderabad. Within a month, so it became very easy for me.
Okay, so to all the groups, now let's have a good applause. Nice to hear different experiences of yours regarding the professional growth in networking. So networking, if you see in medical education, so it builds communication and also shares the knowledge, and conscious creation of interrelated relationships will be there between various students, even teachers, and also the stakeholders with similar interests, either directly or otherwise through intermediaries for the purpose of achieving mainly the goal that you want to achieve, like a common goal or otherwise an individual goal, sharing resources as well as what you call the social communications can be done. If you look into this, so why networking is important? Group intelligence emerges from interaction and diversity. It is especially distributed as defines localization, captures, and defection. For example, if I say more people, more interaction, and more diversity, you'll have more knowledge that is being gained. So more new avenues can be explored in case of networking. If you have a good networking, so you can have good road paths to understand new things, and it also helps to update yourself. Networking is number one way to find job, as Subramaniam said. Good. Over 60% of job opportunities are obtained through networking, and it is not what you know, who you know, it helps in case of networking. Huh? Yeah, please.
It's about building meaningful professional relationships.
Meaningful professional relationship. Good. At workplace, generally the tools for networking will be like meetings, lunch, during lunch period, and also group work. At a professional level, generally the conferences and workshops, and social gatherings like family get-togethers, reunions, festivals, and marriages. Collaboration should be there, where a mechanism of working together in a harmonious way and also a supportive way, enabling to plan, implement, and also evaluate health interventions together. And also it helps in collaboration, helps in enabling to make best source of resources and increase in efficacy. Social networking, as you all know, even social networking also helps in medical education, where you need to have various ways through which you can gather the information, like Orkut, MySpace, even blogs in Facebook, LinkedIn, and these are various other sources through which social networking can be done. And the benefits of social networking, it helps in sense of community, development of friendships, ease with which they can interact with other users, and also ultimately learn from them. Networks can be solutions looking for a problem to solve, or otherwise any opportunity to exploit, and it can be as a juicy gossip too. There are certain limitations of social networking, like authenticity, as Group 1 said, and accuracy for answers to question is to open for debate, and connections made on social networking are superficial and short-lived, and contact sessions make them more deep. So in order not to have this, you need to have certain contact sessions where like higher-end Acme and Famer programs help in contact sessions to make that gap lessen. There are certain tips for networking, like set realistic goals, one should be prepared to have a plan of action, and the networking should be very much organized, and also should have a continuous follow-up kind of thing. Other tips: order resume cards with a brief resume stats, join organizations and also networks, send thank you notes, and get a short and appropriate email address of the concerned persons which you want to have a contact, build a LinkedIn profile and update it often, add recommendations, become active on LinkedIn groups, sign up on Twitter, now it is being X, follow any people who follow you, create an appropriate Facebook page. So finally, I conclude, networking is not about just connecting people, it's about connecting people with people with ideas, and also people with opportunities. Thank you. And before concluding, we as MEU faculty or MEU members, so we are always here for you. We are always here for you to help and guide in your academic growth and academic platforms whenever it is being needed. Okay, thank you very much. The morning session closes, and we'll have a lunch and then come back. What is the time, madam? Time to come back? 1:55. Okay, thank you. Yeah. Yeah, finally, you need to be prepared for your presentations, so where assessment part will be completing, and then each group will be presenting and the other groups will be critiquing on it. Every group need to project. So please prepare it on PowerPoint presentation, and you need to project it and then come and explain. Good afternoon all. So please try to complete it in within 15 minutes. Madam, what about assessment and tools? They have to do it? Yeah.
At least you should make one MCQ, one essay question, minimum.
Vijay? Yeah, it's time. Who is ready? Start with group 1. Which group is ready? Group maroon is ready? Green is ready? Yeah, please. Please come forward. Yeah, please, all of you, you need, each group need to critique it, like what all the things that has gone well, what all the mistakes or what are the things that has to be improved.
Good afternoon, everyone. Good afternoon, everyone. Myself, Dr. Aruna from Group 3. So my group facilitators are Dr. B. Dinesh sir and Dr. Pratap sir, and my group members are Dr. Ramakrishna sir, Dr. Monica ma'am, Dr. Ramni Pratisha ma'am, Dr. Gnanavelu sir, Dr. Mohammed Atta sir. So the competency given for us is to demonstrate on a mannequin correct technique of pleural fluid aspiration. So my specific learning objectives to this is, by the end of the session, MBBS final year part 2 students should be able to identify the anatomical landmarks for pleural fluid aspiration on a mannequin with 100% accuracy, and demonstrate complete aseptic preparation for pleural fluid aspiration on a mannequin. And the third objective is perform correct needle insertion for pleural fluid aspiration on a mannequin, at the intercostal space. And fourth SLY is aspirate simulated pleural fluid using the correct technique on a mannequin. And fifth one is demonstrate all post-procedure steps, including safe needle withdrawal, dressing application and waste disposal. So coming to the audience, my audience are all MBBS final year part 2 students. And the behavior for the first SLO is identify, and the condition is anatomical landmarks for pleural fluid aspiration on a mannequin. The degree is 100% accuracy. And for the second objective, the behavior is demonstrate, and the condition is complete aseptic preparation for pleural fluid aspiration on a mannequin. And the third SLO behavior is perform, and the condition is correct needle insertion. And for the fourth objective, the behavior is aspirate, and the condition is simulated pleural fluid using the correct technique. And the final objective behavior is demonstrate, and the condition is post-procedure steps, including the safe needle withdrawal, dressing application and waste disposal. So coming to the domains what we have taken for this objectives. For the first objective, the domain is knowledge, as it is only the anatomical landmarks we are teaching them, as it is a domain is a knowledge part, and the level is a nose. As it is knowledge, we are using nose as a level of knowledge. And the next objective, it is demonstrate, as it is a demonstration, the domain will be the skill, and the level of knowledge is shows for this objective. And for the third objective, it is the domain is skill, and they have to perform correct needle insertion, hence it is shows how. And for the fourth objective, they have to aspirate the simulated pleural fluid, so it is skill, and they have to show how the level is shows how. And for the last objective, it is the skill, and the level of knowledge is shows. So next, coming to the correct teaching learning methods and assessment methods. First objective to identify the anatomical landmarks, we have chosen small group discussion, and the assessment method is Viva method. And for the second one, we opted for the demonstration, as demonstration of complete aseptic preparation is the objective, and the assessment method is the OSCE station. And for the third objective, perform correct needle as insertion, we have opted for the simulation based learning, and it's been assessed by the OSCE station. And the fourth objective, aspirate simulated pleural fluid, we opted for the simulation based learning, and it is also assessed by the OSCE station. And finally, the demonstration all post procedure steps, we have opted for simulation based learning, and it was assessed by the OSCE station. So these are some of the MCQs we have made for this competency. So what is the minimum distance in centimeters between the parietal pleura and the adjacent structures in all three dimensions? That is safe for a thoracocentesis. And during thoracocentesis, patient suddenly developed persistent cough and chest discomfort. Oxygen saturation drops from 98 to 92, which complication has likely occurred. So for these given these options.
You derived the specific learning objectives perfectly, and also everything is there, and also teaching learning methods. MCQs are good, but why you are not prepared the essay questionnaires? You would have prepared one structured small questionnaires would have been. Otherwise, all other aspects you have done very well. Any comments from other groups? Any comments? Any comments from other groups? Yeah, madam.
Can you just scroll up? No, that where you shown the knowledge. Okay. See, again, when you do the level, the second one, demonstrate complete aseptic preparation, it should be always shows how. Shows comes when you actually perform on a patient. Okay? So, the remaining you put shows how, the same thing you should put. And whenever you describe the audience, when you go back to the audience please, the first two objectives. Who are your audience? Okay, so whenever you tell that in the current CBME curriculum, the terminology is phase 3 part 2. So this final year, pre-final year, all the terminology is gone. So try to stick to that. So it has to be phase 3 part 2 MBBS students. So it's basically for, the whole thing is for those students only, right? Okay, can you just scroll down again? Yeah, so the method of assessment, can you show that? So for this, the teaching learning method, the small group discussion, exactly what are you planning to do? It's correct, huh? It has to be done in a small group if you want better learning, but how will you do it? So this is the anatomical landmark, right?
Yes, ma'am.
So
by showing some posters and all, we can make them to discuss among themselves and they can come out with the...
So it sometimes you can exactly. So you can show some videos, some posters. In fact, dissected specimens can also be shown with the landmarks. In mannequin, you can show, but to reiterate, for them to pictorially describe everything, because you're planning to do assessment with a viva. That means they should be able to describe the landmarks, surface anatomy, etc. So it's okay to go back to anatomy days, get a picture of a dissected specimen, you can show it, because we have our own resources. We need to go and copy some Western resource. We have our own resources, so we should try to create our own resources. So that is a good idea to do small group discussion. And then everything else is simulation and therefore OSCE.
Yes, ma'am.
Yeah, but DOPS is ideally on an actual patient, but can also be done on a mannequin. So SIR says /DOPS, but OSCE is what we do for medical students. That's correct. Yeah, DOPS also can be thought of when you're doing the same for interns.
Yes,
but then on patients, even interns, we won't allow them to do it independently. So it's okay. Can you just scroll down? When you are talking about the audience, you said no ABCD. Audience, behavior is a verb. Condition, you need not describe condition. Here the one condition here is, it is in a simulated environment. That is the condition.
Okay.
So obviously lectures will be in classroom only. No, you cannot say classroom.
Okay, ma'am.
If it's going to be an actual patient, you can say in a clinical OP setting or in the operation theatre setting, but here it is a simulation. So in a simulated environment is a condition for all the objectives.
Okay.
So that is what I wanted to say, condition. Sometimes you need not tell the condition also, it's okay. Degree, what is the degree you have written accurately? It has to be accurately. Okay, or they can say at least 2 times they should be able to demonstrate it accurately. That means you are adding some
specific
value to that. 2 times at least they should do correctly. So they should have at least attempted 4 times. You see? So that kind of degree you can add. But even if you don't add, accurately is obviously it has to be accurately, right?
Yes, ma'am.
So you need not explicitly mention it. So if you mention it also, it's okay, no problem.
The behavior, she put only the active verb. Is it okay, ma'am?
Yeah, basically that's what we want.
You don't want to, the actual, the thing, behavior should include active verb and should be club.
Yeah, so sir says the behavior is actually a phrase or a sentence. We have just put the verb alone, mostly highlighting the verb.
Okay.
But what is expected out of them at the end of the learning session means each objective you have told.
Actually, she put under condition.
No, it is not under condition, it comes under behavior.
Behavior.
Can you just show us that? So identify means condition is all simulated, I told you already. So, identify anatomical landmarks is the behavior. Demonstrate the aseptic technique is a behavior. So, the condition is only simulated environment. So, sir says that complete phrase should come under behavior and not under condition.
Okay, ma'am.
Got it? Okay. Anything else? I think she has done a fantastic job, except essay, sir wanted you to write an essay. Ma'am, you want to add something? So essay also you have to, how will you do essay for this, can you tell me?
So we can give a clinical scenario.
Group members can contribute.
Scenario we can go on.
Like what?
40-year-old man coming to the general medicine with the history of cough with expectoration, breathlessness, hemoptysis. On examination, no history of universal of temperature, loss of weight and loss of appetite was there. So patient on examination there was decreased breath sounds, then long-term palpitations present, dullness present, and chest X-ray on examination all these findings were present. Otherwise chest X-ray and CPC and all the investigation, chest X-ray was pleural effusion, left-sided pleural effusion. So suspected and with cavities and a lot of miliary mottling was there. So suspected tuberculosis of the chest. So advised pleural fluid aspiration and other further investigations like total count AFB, first put on for AFB, CB0 investigations. So pleural fluid aspiration was done. Question, so what is the diagnosis? Modified essay question.
Put the case as brief as possible.
What is the diagnosis? Then how do you confirm your confirmation? Differential diagnosis.
What are the causes of
Management of
Great. So sir has given a lengthy scenario. So you give the key points in the scenario and you want to bring them back to your pleural effusion and management of pleural effusion. So Dr. Raju will complete it.
No, everything was, I think I did not, the condition, behavior, this should come, that only thing is, otherwise you have done very well. This, as a SLO if you read, it is perfect. But only put it in, this one you should, instead of putting in the behavior place, you put it in condition. Okay. Actually, you have done very well. The SLOs are perfect actually, only. Yeah. Even MCQs, they are good quality MCQs to generate.
take today. Good afternoon to you all. Myself Dr. Venu. I am representing team. So these are my team members: Dr. Ankama Sabatini, Dr. Durula Afrin, myself, Dr. Venkatesh Rekha, Dr. B. Shahul, Dr. Dipal Arshad. So our team competency was identify the common etiological agents of diarrhea and dysentery by microscopic examination according to
Whether the pen drive we can transfer and it at that would have been better, I believe.
No, not that. I have to take it.
That's also, they can transfer the pen drive and then it will be easier. No? We don't have pen drive here.
So he is putting it on that connector.
కాదు అందరివి పెన్ డ్రైవ్లో తీసుకోండి, బెటర్ కాదు, లేట్ కాకుండా ఉంటుంది. కాదు, ఫస్ట్ అందరికి తీసేసుకోండి ఒకేసారి, మొదలు పెట్టేస్తాం, మళ్ళీ తీసి పెట్టడం. అందరి తీసుకోమనండి ఒకసారి. అది మళ్ళీ లేట్ తీయడం పెట్టడం ఎందుకు, ఒకేసారి అందరికి తీసేసుకోండి ఒకేసారి. ఓకే.
Changing the pointer. Competency was identify the common etiological agents of diarrhea and separately microscopic examination. So we're going to the specific learning objectives. At the end of the session, phase 2 MBBS students should be able to prepare a wet mount and iodine stained fecal smear from a diarrhea stool sample following standard lab protocols with no procedural risk. Second one was identify robo-assist for at least 3 to 4 commonly encountered parasites causing diarrhea and dysentery when presented with a pre-prepared wet mount slide. Third one was detect and demonstrate the characteristic rapid darting motility of Vibrio cholerae on 2 consecutive wet mounts prepared from the simulated rice watery stool specimen by bright field microscopy, and observe and differentiate motility patterns of morphozoites of Entomoeba histolytica and Giardia lambia on a freshly prepared saline mount of a diarrheal stool specimen with 100% accuracy. And last objective was identify the oocyst of common coccidian parasites like Rhizosporidium or Cyclospora with no more than 1 error per 3 slides examined from the given modified acid-fast stained smear. Observe and differentiate. In domains it will come as nose. This is a practical aspect. So actually this is a practical aspect from DAOP, so I thought of putting.
If you use the word observe, he must be staring into the microscope. You don't know what he is observing, right?
Yes, ma'am. So by observing, you have to differentiate, ma'am.
See, whenever you write a specific learning objective, what is we didn't touch upon this. What is SMART? SMART is specific, measurable. How are you going to measure or assess this?
Okay.
Okay, so observe and differentiate motility patterns now. Instead of that, you can say, describe the different motility patterns of trophozoites. That means it is theory. That means you should take a lecture class or a small group discussion. Then he will be able to answer that. He or she will be able to answer. Observe and differentiate. You cannot assess what he is observing, right? Maybe just, he must be seeing a lot of things but he doesn't know what it is. So, any objective you should write should be easily measurable. That is the message to the audience. So whatever is objective will be SMART, means specific, measurable. What is A? Relevant, time bound. What is A, man? I forgot. SMART. Authentic. Attainable. Yes, thank you. It should be attainable. It should be doable. Okay, it should be relevant to whatever they are learning. Okay. And it should be time bound. Okay, so if you say observe, you cannot measure it. You cannot assess it. So that is not the correct word to use. Instead, you can make it into a small theory answer saying describe, differentiate or describe the different motility patterns of P. histolytica, G. lambia, whatever. Okay?
In this country.
Again, detect and demonstrate. It's very difficult. You can ask them to, how can they demonstrate it? The Vibrio cholerae have to know how do they demonstrate it, right? So describe the motility of Vibrio cholerae. That's all. That is a theory question again. It is an objective based on theoretical knowledge. You have to plan your teaching learning according to it. See, the overall competency given looks like only skill based, but how will you get a skill without any knowledge base? You can't get a skill. So you have to incorporate knowledge based activities and objectives also into your for that particular thing, and therefore your teaching learning methods will also be a combination of everything.
Okay. Going by the objective 1, the audience is second year MBBS students. Behavior is we need to prepare a wet mount and stain fecal smear. So condition is we are giving them a diarrheal stool sample and they should be following standard lab protocols, and degree is there should not be any procedural errors. And second one is they have to able to identify a name that comes under action word And the condition, when presented with we will present them with a pre-prepared wet mount slide. And a degree is at least 3 to 4 commonly encountered parasites they have to identify. And third one is they have to detect and demonstrate characteristic darting motility, and we will be providing them with simulated stool specimen. And the modality they have to find is by bright field microscopy. Degree also 2 consecutive wet mounts. And fourth one is they have to observe, as member we have to describe the different motility patterns, and we will be providing them with a saline wet mount, and they should be doing it with 100% accuracy. That comes under degree. And last one is they have to identify a oocyst, and we will be providing them with modified acid fast stained smear, and there should not be more than one error, and they will be examining some 3 slides. So that comes under degree. So these are my domains. And coming to the next one, the domains. So first one, we asked to prepare a wet mount and iron stained fecal smear from diarrheal stool sample, and domain is S, so they have to show. Next level is dust, they are doing, so it comes under dust. And chorus, yes. Then second one, they have to identify or assist at least 3 to 4 commonly encountered parasites causing diarrhea and dysentery. So domain comes under knowledge and also S. And level is they have to know how to identify or assist. And third one, that is we have to describe and demonstrate characteristic rapid darting motility. So they have to know regarding the what is darting motility, so that comes under knowledge, and they have to show in 2 consecutive wet smear that they have found it one. And level is they have to show how. Fourth one is observe and differentiate. They need to differentiate, so for that they need the knowledge, so K. And S also they are going to show the differentiation, they are going to describe the differentiation, that's why S. And level is SH. And last one is identify the oocyst of common bacterial parasites, so same KS, and they are going to show, so S.
And why they put the does?
Because they need to prepare the wet mounts on their own. They are going, we demonstrate them after the.
Then you can put the shows how.
Shows how, yes sir.
It doesn't.
So I had one doubt sir actually, so
shows how.
Shows how. Shows how. Okay, sir, thank you. So next one is regarding teaching learning method and assessment methods. So first one we are going to prepare, so this comes under DOAP, and we have certain DOAP checklists, like before starting any procedure we have to check whether we have adequate slides we have, or whether our simulated stool specimen is ready, and even the microscopes are working or not, they are in proper condition or not, that we have to check. And there are certain things which you have to check before proceeding with DOAP sessions. Next one is identify OASIS at least 3 to 4, so that comes under a small group discussion and DOAP. I will mention that in later slides. And assessment method will be a type of Austrian spotters. And third one will be to demonstrate and detect the characteristic rapid darting motility. That also will be under DOAP session because we are going to demonstrate it. And next one, observe and differentiate motility patterns of Enteroparasitica and Giardia lambia. That also will come on DOAP, and for that also we have a DOAP checklist. And last one is to identify oocyst of coccidial parasites. So we will be conducting a small group discussion along with DOAP sessions also. And for them we will be providing the OSPI question and also with the spotter. So now coming to teaching learning methods. So number of students are 150 number. So time required as calculated approximately 5 hours. And the methods we are going to follow are large group discussion methods, small group discussion methods, and also DOAP session. So coming to first large group discussion, so duration will be of 1 hour, and participants will be all 150 students. Faculty required 1 person is enough for 150 students. And so the objective for the first session will be to provide cognitive framework before the skill session. And the contents
in a large group discussion.
Which one, sir?
Large group discussion duration 1 hour.
Lecture, sir. Lecture 1 hour, sir. 1 hour lecture.
You specify the whatever it is.
1 hour lecture. Yeah. So that means we'll be having like introduction, definition, agents causing diarrhea, different microorganisms, lab diagnosis, and also we have some case-based scenarios. And infrastructure required will be a lecture hall, and we will require an audiovisual projector and a microphone. And the advantages of large group discussion will be we can cover large group of students and at the same time, and provide standardization by preventing variation in teaching, because one teacher is going to take the class, so it will be same for all. And the high quality of AV projection allows clear demonstration of microscopic details, which is a core of the study. And disadvantages of large group discussion is there will be risk of passive learning for students, because each student will be of different levels. We can't say they all will be same. And second one is didactic in nature. The lecture will be only one-sided because we can't concentrate on 150 students at the same time. So it will be didactic in nature. And the next one is faculty preparation. So we need to prepare high definition slides along with certain clinical scenarios to make the session little bit interesting. And which also we should ask critical questions. For example, like we should ask them which virus can be detected by light microscope. They will be because virus cannot be detected by light microscope. We need a electron microscope for virus. So these type of questions are something called as bigger questions. So coming to next one will be small group discussion, and small group discussion will be for 1 hour, and here participants will be divided into 5 groups, 30 students each, and faculty required to be 1 faculty for each batch. So objective here is to reinforce identification features and correlate findings with clinical history. We provide them in history also, and here we assure that they get cognitive and interactive skill will be more focused on small group discussion. So here the contents will be demonstration of microscopic images and videos related to agents causing diarrhea and dysentery. And infrastructure, a demo room is okay with AV projector, or we can have laptops also. Next one is advantages. So what is the advantage? It means there will be active engagement of the students because it's a small group. We can concentrate on each student. Second one is peer learning. So the students who are a little bit more studious can teach the weaker students, and makes the students feel comfortable to even ask silly questions because it is a small group. Large group, they will be afraid whether we can ask this question or not, what they will think about faculty, what they will think about us. So they can ask silly questions also. Next thing is faculty preparation. For that we should have a checklist for facilitating, ensure all groups cover the same points. And printed handouts of microscopic imaging, also clinical scenarios, because it is a small group we can easily give them some handouts and also some videos we can show them. Then coming to DOP session, and here we can have for 3 hours because we will be having only 3 batches, that is 150 students, so 50, 50, 50, 3 batches each will take for 3 days, 3 hours. Faculty requires 1 main demonstrated along with 3 skilled assistants. So objective is to acquire the psychomotor skills for preparing and interpreting the slides.
You want?
Yes, sir.
Is it possible in that sense?
One session for each batch, sir, 3 hours.
No, 30 students will come, right?
Yes, sir. 30
or 50?
50 batch, sir. 50 batch.
50 students.
Sir, because we already demonstrated STD and HEPA. Okay. Just they need to do and get our signatures, sir. So
Okay.
1 hour is more than enough.
Each 50-50 will come in 1
Yes,
hour.
sir. Yes, sir. 1 hour.
And at the same time, you have to think of the scenario or the facilities available in this setting.
We'll get the checklist ready, sir. Before they come, we'll...
You have 3 skilled assistants?
Yes, sir, we have, sir. Yes, sir. So contents here will be demonstration of standard operating procedure, which includes macroscopic examination first of the stool, wet mount preparation, usually you saline mount and iodine mount, and focusing of microscope at low power and high power. These are the things we'll be telling them. And infrastructure required is microbiology lab, and they should have at least 75 qualified microscopes in working condition. And advantage of OCD is mastering the skill of microscope by performing. So always microscope, because by viewing it we cannot develop that skill. We have to do it to ensure that we are well versed with microscope. So we have to do it, and immediate feedback can be given by the faculty. When they finish that, immediately faculty can give the feedback. That is one advantage. Disadvantage is requires a functioning microscope for every 1 to 2 students. That is very difficult actually for getting so many functional microscope at the same time. And next one is requires more faculty, and there is also risk of biohazard because even though there is a simulated stool specimen, there is a chance of getting infected. So that is one more thing. Time management. As sir asked, 1 hour, maybe we have to plan such way that it will take only 1 hour. So that is very important. Next one is faculty preparation, verifying every microscope is working as I told, and preparation of simulated specimen containing microorganisms. That is the work of the faculties. Coming to formative process, all this we will assess the students. We will assess the students by giving them a case scenario. We will just give them a case scenario and give different options. Like for example, we gave a case scenario for Giardia lambia. So this is one way to trigger them. Next one is OSCE session. So as we told, there are OSCE stations will be there, and one station will have microscopic identification of common agents causing diarrhea and dysentery. Next is the clinical scenario. Again, they will be displayed at the station, hospital station only. And the card for students, we will just give the instruction cards at each hospital station. There will be instruction card, 1 to 4 minutes for each student. So it will be based on microscopic images which we showed them in small group discussions, and identify the organism shown in the slide. Next, mention one characteristic microscopic feature and mention one key feature, clinical feature associated with this organism. So like this we can conduct the OSPI station. Time given for that 4 minutes. Yes, sir.
You should structure it such a way that in 24 minutes they should be able to go through the case and also able to go through the question and answer. It should be as brief or as crisp as possible.
So this is the OSPI checklist. Will be assessing them under criteria like selecting correct magnification for scanning, high cover or accordingly we will give 0.5, that is half mark. Then recognize RBC pulses different and we will give them 1 mark for that. And identifying OVA, that is very important. So for that, with the core of this test, so we will give them 2 marks. And differentiating between pathogenic and non-pathogenic organisms will give half mark. And last one is likely diagnosis, 1 mark. So as there are certain short answer questions also we can give them as assessment, like enumerate the different organisms causing diarrhea and dysentery, and also we can ask them to mention difference between amoebic dysentery and bacterial dysentery. So these are some of the short essay questions.
Comments from the group? Sorry, I intervened. Yeah. I came a little bit late, so I can't comment on the things which are already taken place.
Yeah, excellent presentation. Actually, you discussed so much about the teaching learning methods, advantages and disadvantages, what you have selected, and overall presentation was very good.
One thing is small group, you have said about 30 members. Yes, so as per norms, what is the small group that has to be? 12 members. Max to 15. Less than 15.
Another thing is last comment here, short answered questions. When you make this one, mention the number you put, 2 or 3 or 4. Then only that will become a short answer question. Just mention the difference between means it will not. Okay. Thank you.
Thanks. Yes.
So all documents has to.
Next.
Group 2.
No, this is first group only presented.
No, the third group 3 has presented already.
Already, yeah. Who is presenting?
Very well. Actually, earlier they were not there.
This is the G batch.
And also all the
this is lesson cleanser, the one which sir circulated for NAT. I have PPT also. No, PPT. Good afternoon, everyone. So myself, Dr. Savita, Assistant Professor, Department of Anatomy. So I am representing Group 2, Pink. My group members are Dr. P. Sai Krishna sir, Dr. M. Piyusha ma'am, Dr. M. G. Babita Reddy ma'am, Dr. Sripriya ma'am and Dr. K. Jagruti ma'am. For us, the competency given was from physiology, discuss various RFTs with its physiological significance and clinical implication of renal clearance. So at the end of this session, each MBBS phase 1 student should be able to hear our audience's phase 1 MBBS student and SLOs. So we have made 4 SLOs from this. Describe the normal renal function using a diagram with at least 80% correctly. Enumerate and explain at least 4 RFTs. Define renal clearance and list 4 clinical implications, scoring minimum 70% in reasoning out question. Analyze and compare the abnormal RFT parameters with relevant clinical implication using the given case vignette. Here we have mapped it to the Bloom taxonomy. This is understanding level, understanding and remembering level. The third is also remembering level, and the fourth will come to analyze level. So everything is of knowledge domain. Sorry. And here the teaching learning methods for each one. For first 3 we have put it as large group teaching, especially in lecture, and the last one as case-based learning, where we will give a case and the students will be asked to sort out in groups, small groups. And the assessment methods for the first 3 MCQs, modified essay question, short answer question, and here we can give reasoning out and OSPI.
Fourth,
and assessment, it is example for what can be given. So long essay, describe about renal physiology, mention any 4 RFT parameters, define renal clearance,
analyze,
enumerate clinical implications of renal clearance. So we have divided it into 5 plus 2 plus 3 plus 5. And for MCQ we have given one example, and short answer, define renal clearance and explain its clinical implications, explain the significance of blood urea nitrogen in assessing renal function.
Can you please go back to the previous one?
Analyze and compare the abnormal RFT parameters with relevant clinical implications using the given case vignette.
So, give the case.
Yes, sir.
Case scenario.
Yes, sir. So in small groups we plan for case-based learning,
Okay.
where they will need to reason out and they have to compare
Okay,
with
then
the normal
then
values.
it's okay, fine.
And with this reasoning out question, ma'am.
Okay, that is theory.
And OSPI.
How do you do it in OSPI?
A clinical case will be kept and with values, ma'am. And below that, we'll ask questions.
Okay, interpreting the clinical values on a paper case. Okay. Yeah, it's a response station. Okay, very good.
Lesson.
Okay, excuse me, go back to third. Sorry, I have 1 minute. Define renal clearance and identify 4 clinical implications, scoring minimum 75% in OSPI.
I think.
No, if you keep... So you should also see whether it's feasible across the 150 students. We have slow learners, okay learners, high achievers. If you keep a target of 75, 80%, 90%,
at least 50 will be on.
It's not achievable because it's a small group, you've kept it like that, but still you'll have a varied group of learners. So instead of saying giving marks, at least they should be able to identify it correctly minimum 2 times, 3 times. You have to understand these are all, you are setting very high standards for the teacher as well as the student. So if you want to achieve this, it may not be possible in all situations. So keep the level a little manageable. So it is very nice, ideally it should be like this, but sometimes it's not feasible. So you have to balance between both.
So in a way that, anyway we will be kept in case-based, no sir? So they have to give us the clinical implication to that case. Okay, okay sir. Yes.
Same point I will add.
Okay, the same point what you have to understand is also, the first three objectives can be combined together in a large group lecture. That's how you should plan. You can't have one objective in one lecture class.
Yes, sir.
Then you will be having 4.5 years is not enough. So you should also show these 4 objectives, I will do a large group session. This, I will do a DOAP or demonstration. This will be a practical lab class. So you have to get the hang of
So for that,
putting it together. Yeah.
one lecture I have prepared a lesson plan.
Very good. Okay, you're going to show us a lesson plan. Excellent. Okay, got it.
Word document.
Okay, Dr. Ramya has got a point, then meanwhile you can show us a lesson.
10 marks. Next slide. Yeah. So I just had one query here. The long essay question. Described about renal physiology is very vague. It's like the whole of renal system. So you have to either specify a single, maybe you can say describe the sodium absorption, because that is very important for renal physiology, or you can split it. Maybe you can have 3-4 long essay questions, tubular absorption for one, concentration and water reabsorption, because describe about renal physiology as such, and then you have added more things, so that is a little vague. So that you can have more long essay questions. That was the only point I had to make. Thank you. Yeah, counter current mechanism, yes. Concentration of urine and yes. Yeah, go on.
Word document. He has to. So here we have the SLOs in lesson plan. We will start with SLOs, and the duration of the class is 1 hour. The same SLOs I have copied here, and for instructional components I have added one case scenario which will be acting as set induction for the lecture. Then we will be talking about the normal renal function with the neat label diagram. I have added the time also. It is coming up to 50 minutes, sir. So 10 minutes I have left. Analyzing with at the last I will be correlating with the lab reports for 10 minutes. And here for evaluation during the class I can ask for question bus grouping. MCQs can be asked, and formative summative assessment.
If anything, other groups also can comment, whichever is presented, not only the, you other participants also should comment on the.
Please do the necessary corrections and then post to the group. Those corrections that have been told, please do them and then post to the group.
పెన్ డ్రైవ్లో తీసుకోలేదు మీరు, పెన్ డ్రైవ్లో తీసుకోలేదా? ఇది లేట్ అవుతుంది లేకపోతే ఒకసారి పెన్.
Yeah. It's group 5 Maroon. I am Dr. Subramaniam. My group members are Ravi Kumar sir, Sainath sir, Allah Karthik sir, Ramya ma'am and Aisha ma'am. Competencies: describe the etiology, pathophysiology, pathology, gross and microscopic features, diagnosis complications of pericarditis and pericardial effusion. At the end of this, second year MBBS can define pericarditis, pericardial effusion. It's based on classroom teaching and 100% accuracy in recall because its definition. We expect 100% accuracy and describing etiopathogenesis and pathophysiology of pericarditis and pericardial effusion based on classroom teaching with diagrams, and they have to explain it sequentially because it's a pathophysiology, etiopathogenesis, and describing the gross and microscopic features of different types of pericarditis and condition. We teach them based on gross specimens and histopathology slides, and degrees, it's correctly identify more than 80% of the features. Like in histopathology they can identify 80%, and enumerate and interpret the diagnostic investigations of pericarditis and pericardial effusion. So clinical scenarios and lab investigations, we can, based on this we can teach them, and at least 80% of the criteria we can expect. And explain the complications of pericarditis and pericardial effusion. Based on case scenarios we can teach them.
The objectives when you are writing, everything should include here. Can you go back? You have to write the condition degree also there. you are not, here you are written, but when you are writing that, because whenever you are writing the SLOs, you are writing in this pattern, not in this pattern. So here you write the completely A, B, C, D, all the components you write in there.
And some of the objectives, it is very difficult to assess 80% and other things.
Yeah.
So whenever that list and list timer at that time you can bring 80% or something like that. Otherwise, say for example, describe. See, the third one is describe gross and microscopic feature. Of course, if there are numbered, yes, if that is numbered, it is there, you can easily, you can expect that degree of this thing, achievement.
We are teaching, we are giving some 6 to 10 points. So from there, we
yes, if that is the scenario, it is fine. But if they want to describe it, then it's difficult to expect the degree.
See, pericarditis in gross specimens and histopathological slides. You have to write. Then why you are putting doc here? Condition.
typing errors.
Yeah, anyway, this everything should be there here itself. Huh? Okay.
Condition you need not mention its classroom or all that is condition is it
By theory.
simulated or is under some other condition. Condition doesn't mean the situation or the room in which you're taking class.
Yeah.
You need a condition, you don't need to mention criteria. Most important for audience is clear and you also if you want to add you can add, otherwise you can leave it. For everything you cannot say 80% they should get marks. It's not doable, right? So it'll be very practical. Okay?
TL methods. So for pericarditis and pericardial effusion, lecture. It's a lecture and we can give MCQs and describing etiopathogenesis and pathophysiology, interactive lectures and short group discussion will do better, and case-based discussions and assessment based on MCQs, short notes and viva. Describe gross and microscopic features, types of pericarditis. We can ask them to, based on here we can use that is specimen demonstration, slide demonstration and short group discussions. So we can use assessment DYAP here and OSPI and practical spot test and enumerate and interpret diagnostic investigations. So for this we can use interactive lectures, MCQs will do better here, and complications and pericarditis and pericardial effusion we can give case discussions, case based scenarios and assessment based on short SAQs.
No, here you can't use the short answer questions. Here you can't use short answer questions. You can use, isn't it, short answer questions. Yeah. Here viva also you can use the first one. So like that, whatever ways you can assess, you can mention that one.
DOAP is a method of teaching, but it's not a method. DOAP is demonstration, observation, assessment. That's a method of teaching.
Yeah.
It is not for assessment. Assessment is OSPI.
OSPI.
DOPS is direct observational procedural skills, DOAP is a method of teaching. Okay, right. Yeah, I think this is the first group who has compared and contrasted the teaching learning methods. All of the groups proper. Yes, quickly tell us.
Yeah.
Oh, they did it, sorry, I missed it then.
Interactive lectures, advantages are covering large content time, and disadvantages are passive learning, limited interactions, infrastructure aids, classroom and projector, audio visual aids, faculty preparation required, standard lecture preparation is required, and method to short group discussions, and better hand-on demonstration and more interactive. The disadvantages are require more faculty, infrastructure and time consuming, and infrastructure needs are microscopic and slides and demo rooms are needed for this, And faculty preparation, arrangement of microscope and faculty may be required. Method 3, case discussions. So develops clinical reasoning engagement. Advantages are develop clinical reasoning and engaging the students, and disadvantages are needs prepared cases, that is it will take time consuming, and infrastructure okay ma'am, it's okay. Faculty preparation, case designing is required.
Yeah.
Go on, please.
MCQ, which of the following is the gold standard investigation for diagnosing pericardial effusion? Chest X-ray, ECG, echocardiography and cardiac MRI. So it's echocardiography. All of the options seems to be clear options.
So better not to use abbreviations, even though ECG, you all know what is ECG. It should be electrocardiogram.
Yeah.
MRI should be magnetic resonance imaging.
Yeah.
Maybe I ask you to generate the clinical weakness.
No, next is showing, sir. Next cutter.
Yeah.
Go the next one. Yeah.
A 58-year-old woman with a past medical history of SLE
Okay.
presents to emergency room with sharp chest pain. She reports that it is worse with inspiration and gets better when she leans forward. On physical examination, there is a friction rip that is loudest when she leans forward. And ECG shows widespread ST elevation. So most likely diagnosis. It carries 2 marks. Etiology and pathophysiology 3 marks. Explain clinical features 5 marks. Investigation 3 marks. What are the complications? 2 marks. Total it's.
Is it modified ST?
What is the problem with this? It's a very well thought out case scenario. So a high achiever will be able to get the diagnosis.
We are in pediatrics, we are giving this, they are answering.
Okay, yeah, you are teaching very well, they're all answering. I am not teaching so well, they won't answer, no. So you have to, most likely diagnosis, the better thing will be give the differential diagnosis. So at least 2 marks they will get. And then describe etiology and pathophysiology of the most likely one next. Even if they come to the second likely, you still can give marks to those students.
Correct.
Because they may not hit upon the correct diagnosis every time. So it becomes an all or none phenomenon, therefore it is not fair on all students. So you should look at the average and the below average students also. So you have to tweak your questions a little bit, but the scenario is excellent and you are nicely given, divided and given the marks. So that's why it is a modified essay question. Very well done, but just remember you have to be easy on the low achievers also.
So, to engage now herniation, now herniation will take place. And my
That I could.
Good afternoon everyone. Myself Nagijyoti. So I am presenting a case from group 4. So my colleagues and so with the inputs from them, and they are Gautam and Anil Kumar sir, Prabhakar and Mohammed. Actually, that case topic is, I am phase 1 teacher, but I am presenting phase 3, part 2. If any mistakes, please excuse me. So, demonstrating the correct technique to examine the patient with hernia and identify field-based technique. The competency number is SU 28.1. So that learner should follow the ABCD criteria. So the audience are phase 3 part 2, this one, part 2 students, and the behavior perform systemic examination of a abdomen, especially in the groin region, since the patient is having hernia. So they are going to examine the different techniques of hernia. So condition is they can given simulated models as well as the real patient, and the degree accurately perform all the steps in order. So next, identify the presence of hernia clinically. So during bedside examination, and detect hernia in different types, so in different cases. So distinguish between the direct and indirect hernia by examining the patients using physical examination, and correctly differentiate the hernia as well. So differentiate inguinal from the other types of hernias, for example femoral hernia, using anatomical landmarks. So the degree of this one is identify the type correctly in all standard test cases, recognize the complications. So at bedside assessment, then complications promptly and safely. Okay. So by the end of the class, the students must know, they should recognize the complications with the beds, with the patient, live patient, identify the signs. Okay. The complications like strangulations. Okay. Okay.
Actually, those are the elements given, audience, behavior, condition as well as degree. Okay. So whenever you are framing the learning objectives, it can come as a sentence. Because if it is fractioned like this, sometimes you may lose out the flow. Okay. Only thing is, what you have to remember is, wherever it is possible, you should make an SLO which will address all these 4 elements. Complete. Yes. You can underline that.
So coming on to the domains, and they should follow the stepwise examination to detect the hernia. So domain is, they should know that is skill how, and department is surgery department. Identify the clinical features of the hernia, distinguish direct from the indirect hernia, differentiate inguinal hernia by using anatomical landmarks with the other hernias, recognize signs of So teaching learning methods and assessment methods can be done after a demonstration of the hernia by skill method, and perform stepwise examination of hernia. So teaching learning method, it could be bedside demonstration and skill lab sessions also. So that they can assess we can assess the students by doing the ASCII, and identify clinical features of hernia with the small group bedside teaching. So with the Viva as well as the MCQ questions, and demonstrate direct and indirect inguinal hernia by demonstrating the standard patient and manicure, and by asking ASCII different stations, and different inguinal hernia, difference between the inguinal and femoral hernia with the anatomical review. They should know the boundaries of the inguinal canal and contents of inguinal canal, femoral canal and everything. So by asking short answer questions, and recognize complications, interaction with the case based.
here wherever possible, it can be taught in the bedside itself, right? Only limitation is when you are taking a case, each time each student should be able to examine. That can cause some problem to the patient. Otherwise, if it is possible, well planned out, it can be done on real patient. Because in standardized patient you may not get anything, right? If you, what about, because, no, they are inguinal hernia in standardized patient.
Different techniques,
What,
ma'am.
as far as
Okay, so who is a standardized patient? Can you tell us? Otherwise, we'll ask the clinicians in your group. Define a standardized patient. Don't look into your phone. Sorry, yeah, Anil. Sorry? Who is a standardized patient or who is a simulated patient?
Simulated patient is who can mimic the
Patients who are coming to OPD are patients. Standardized patient means somebody is acting like a patient, like an actor, like today, who was your standardized patient? Venu was a standardized patient, right? So standardized in the sense you already teach him what he has to respond to the students' questions. So standardized patient essentially is used for communication, counseling, to some degree examination, general examination, auscultation, all those things. Examination of a hernia, they won't have a hernia in the first place. And you can't strip them and examine them because they are not real patients and you cannot demonstrate. It is better to do with a real patient instead of a standardized patient. And we don't have mannequins which have hernia findings. We don't, even in the Western countries, they don't have such mannequins. Okay, either you have to create, because one of my colleagues in Ramchandra, she created a mannequin for breast examination and axillary examination, mimicking almost normal human surface. So axilla also she created, that was her PhD project. But it's very difficult. So here it has to be only the real patient. There is no simulation in this. But you can do simulation for landmarks as you rightly said.
Anatomical
Okay, anatomical landmarks you can do that. Already marked out or with some pubic tubercle, some protuberance you can create and you can ask them to describe the inguinal canal, the femoral triangle, everything that you can do. But hernia findings has to be on a patient. Or what else can you do? Suppose you don't have enough patients. We are lucky we have enough patients. Suppose you don't have enough patients. So what you can do is, you can show them, they won't actually do the examination, at least you can see, show videos of people getting examined with their patient's permission of course, but ideal to do in a actual patient. What else you have written?
Different teaching learning methods, bedside teaching and skill lab and case-based discussion. So advantages and disadvantages may be.
Okay, that's fine.
Finally, we can assess the patients by doing essay question, structured based essay question. So by giving a case scenario questions as well as the short answer questions and MCQs also.
Wait, don't run so fast. Come down, I want to see it. Hold it.
Describe the general principles
Preparation for examination of patient with the suspected hernia.
Okay. So basically, because the competency is essentially looks a little skill oriented, your scenario is also this, your questions are also based on that. The theoretical knowledge behind the skills you are trying to get. That's fine. Can you show the MCQ please?
During examination of groin swelling, expansal calf impulse, best elected by. So asking by MCQs.
Okay, but asking the patient to perform a Valsalva maneuver, placing the stethoscope over the swelling, palpating the swelling while the patient coughs. See, actually these options are all very jumbled. It doesn't make sense. Okay, so
An expansile cough impulse is best elicited by, so you can't keep distractors that are not anywhere close to the answer. Yesterday Dr. Raju showed, no? The distractor means plausible. They also should appear, okay, maybe it's also correct. When you are saying expansile cough impulse, why should I bring the stethoscope at all? Even any MBBS first year student will know that. So it's better you put distractors which are as close as possible. This is what happens when you are in a hurry to make the MCQ, and whatever comes to our mind we put it as a distractor. That is not correct. That is not a very well done MCQ. It's okay, don't take it personally. This is learning we are doing together. Which finding best distinguishes an inguinal hernia from ephemeral hernia?
Presence of pain.
Why? Inguinal hernia can't have pain, huh? It's correct for both. Location related to the pubic tubercle, presence of a cough impulse, age of the patient, reducibility. Again, it's very arbitrary. Okay? So no one answer is actually very correct. Okay? Whoever made this MCQ has not made it correctly. Chat GPT use பண்ணா இதான் பிரச்சனையே. ஆமா. Hernia that reappears even after occluding a deep inguinal vein. Okay. The third MCQ seems to be a sensible one. A hernia that reappears even after occluding the deep inguinal vein is most likely a... Okay, this is accepted. Go to the next one quickly. Last. Avladana? Okay. Thank you, Nagajyoti, for braving my questions. You should clap for ma'am. Extra.
Yeah, thank you very much. I think probably now you're all well versed with the way you need to, from the competency, so this is the thing where you need to understand now, competencies are available in the website from the curriculum volume, from your specified departments. So check your competencies. From the competencies you should be able to derive the specific learning objectives, you should be able to know the domains, and also you should be able to know the tools, especially the teaching learning methods and also the assessment methods. So try to check your competencies and make sure that you can derive your own SLOs. So before starting next session, there are 2 more sessions and in between we'll be having a tea break. So I just ask each group to come forward. Each group please stand up. Please, each group please stand up. Group 1 please come over here. Group 1 please come here. Stand 1 arm distance. Please stand in a line with 1 arm distance. Itla tirigandi. Or otherwise you can turn this side. Stand with 1 arm distance. 1 arm distance. Group 2 in the same way. I think other groups also can do. Stand in a line with 1 arm distance. Come here. 1 arm distance. Please check for 1 arm distance. Group 3, Group 4, Group 5. You can make your own arrangement. This is off one. Paper weight. Even side also 1 arm distance should be there. One arm distance. Video real. Come this side. All at one end. Better. You can make your own space. Come little front. Okay. Now I give some instructions. So based upon the instructions, please form the line fast. Form a line with 1 arm distance. Okay. The instructions are So whatever I say, you have to do the opposite. Okay, if I say turn your head to the right, you should be able to turn to your left. If I ask to sit, you have to stand. If I ask to stand, you should be able to sit on your knees. Okay, and if I ask to raise the right hand, you should be able to raise the left hand. Okay, right? Any doubts? No, I mean to say opposite hand. Okay, a good question. Yeah, is it okay? If I ask to put the right hand, you should be able to lift the left hand. Okay, right? Right, everyone ready? Gautam is ready. Not okay. Opposite. Okay. Not okay. Turn your head to your right, up, down, sit, straight. Okay, onto your knees, stand up. Okay, don't sit. Up, raise your right hand. Raise your left hand, both, I need both the hands up. Both the hands up. Okay, turn back, turn front. Okay, please go to your consent seats. Thank you. No, the game is over, you can go back to your seats.
So good evening all. So the tea will be served at your places. So we'll go to the next topic for today. So no prizes for guessing these people, isn't it? Who are they? Krishna and Arjuna. So can you tell anything about the kind of relationship they had? Mentor-mentee. Because the timetable, the schedule says that that's the topic for now, right? So at the end of the session, the participants should be able to define mentoring and enumerate the core principles of mentoring, describe the need for mentoring in medical education, enumerate the various types of mentoring, describe the qualities of a good mentor, enlist the do's and don'ts of mentoring, and finally, describe the CBME guidelines about mentoring. So before going into the topic, we'll just see where this word mentor came from. So you would have heard about this story, the Odyssey. It's a Greek mythological story. So it's the story about a king. The king's name was Odysseus. He is the hero of the story. He had a son whose name was Telemachus. So this king, when he went to a war with Troy, there is nobody to take care of his son. So he called his friend, and that friend's name was Mentor. So he called his friend and told Mentor to take care of his son and advise him in the absence of King Odysseus. So this is the first reference to the word mentor in history. So we will be seeing about what is mentoring, why it is necessary, and a little bit about how do we do this mentoring in medical education. Has anybody had mentor or mentor-like figure? Can anybody tell? Can you lift your hand? Briefly. My mentor is my mom. Anybody else?
My mentor is usually my brother, ma'am. Whatever I do, mentorship is my brother.
So you've all had, even though formally we wouldn't have a mentor, as in we didn't have mentor-mentee program in our undergraduate curriculum, but in our life we've had mentor-like figures, isn't it? So all of us are aware little bit about what mentoring is. So it encompasses a whole lot of things. A mentor would give us motivation, advice, show us path to success, show us a sense of direction, will help a little bit about coaching us, give support, help us reach the goal, will train us. So different aspects are there in mentoring. So if we can, there are many definitions for mentoring. This is one of the definitions. So mentorship program, it is a process whereby an experienced, highly regarded, empathetic person guides a younger individual in the development and re-examination of their own ideas and help in both personal development as well as professional development. So the mentor will help the mentee in both personal as well as professional development. So this mentor-mentee relationship, it blossoms from the desire of an experienced veteran to give and from the desire of an inexperienced person to grow in life. So mentee, as we know, is a person who is getting mentored by the mentor. He is usually a person who is less experienced than the mentor. So like we saw the picture, some of the ways in how Krishna helped Arjuna. Can you tell? Krishna helped in decision making, gave words of wisdom, guided him, helped solve moral dilemmas, showed the life purpose, gave emotional support, and actively listened to Arjuna's fears and self-doubts. These are some of the aspects in which Krishna mentored Arjuna. So ancient Gurukuls, if you look at our own history, the ancient Gurukuls also, it was a place where the Shishya or the disciple would undergo an overall development in the life in both professional as well as personal aspects under the guide of a Guru. Can anybody identify who this is, these two people? This is one of the famous quotes. He who studies medicine without book sails an uncharted sea, but he who studies medicine without patience does not go to the sea at all. Ma'am? Yes. So that is Sir William Osler. And what about the other person? Who was William Osler? He was a renowned physician, and in medical education he has played a very important role. He showed what bedside teaching is. He designed the residency program in Johns Hopkins Hospital, Maryland. And what about the other person? Was his student, who later he mentored, Harvey Cushing, a famous, renowned neurosurgeon who worked initially under Sir William Osler, and later he himself became a very renowned neurosurgeon, conducted almost 2,000 neurosurgeries throughout his life, and later Harvey Cushing wrote the biography of Sir William Osler. So there is an example for mentor-mentee relationship in medical education even before this term was formally introduced. Most important question, why do we need mentoring? We did not have a formal mentoring program. Why is it necessary now? So if you look at students, they come from a very safe environment. They would have studied at their homes under a similar background. Students, very few students in their classrooms, a very safe school setting, and suddenly they come into medical college where they are sitting with 150 students. Different students from different backgrounds are coming together and sitting. There's a lot of peer pressure, a lot of emotional immaturity, and on top of all this there is the stress of an overall complicated CBME curriculum or a medical curriculum which is very, very different from what they have studied all these years in +1, +2 or even in school. So this is one aspect why mentoring is needed. We have seen these things regularly in newspaper, heard news about this, isn't it? Ragging, peer pressure, toxic seniors, studies, sleep deprived, duties, patients, theses, mental health, sounding very familiar, isn't it? So these things, there is a lot of stress on the students, both undergraduates and postgraduates, and that warrants the need for a mentoring program, which is why the National Medical Commission has introduced this formally as a part of the CBME curriculum. So some of us would have answered this survey. Do you remember the NMC task force survey that was done a couple of years back? So an online survey was done, mails were sent to medical teachers all across the country, and what they found was 7,115 students were diagnosed with mental health conditions throughout the country. It included both undergraduate students as well as postgraduate students. Some of them were having one mental health condition, some were having two, and some were even having 3 mental health conditions diagnosed together. So there's a lot of stress upon mental health in students in the country. So these are some of the problems: failure to cope up with the curriculum and studies, pressure to excel, emotional issues, lack of peer group, lack of friends. In schools and in college they had their own set of friends, and suddenly in medical college it's not the same anymore. And occasional disciplinary issues. So all these require a mentoring program, a formal mentoring program for especially undergraduates. So what are the different types of mentoring? Informal mentoring. This is what happens outside of educational institutions. Then that is called as peer mentoring. What is mere peer mentoring? When the postgraduate is sort of mentoring the undergraduate student, or an intern is mentoring the undergraduate students, that becomes mere peer mentoring. And then there is virtual mentoring, which is e-mentoring. There is no direct interaction, but all the mentoring happens via emails or social media platforms or over phone calls. So that is e-mentoring or virtual mentoring, where there is no direct interactions. And there can be multiple mentors also. Sometimes a person can have an academic mentor, a research mentor, and mentor for some other aspect. So different mentors can be present for one person. That is called as multiple mentors. So whatever is the type of mentoring, there are different stages in mentoring. What are the different stages? The first one is initiation stage, where the relationship has just started. That is the mentee and mentor, they've got allotted. So that is the first phase of mentoring. The next is the cultivation phase, where the relationship grows. Most of the activity of the mentoring happens in the second phase, that is cultivation phase. In the third phase, that is the separation phase. Separation phase is where the mentoring is over, and in our case it is the intern who will be leaving the institute, and there will be no more mentoring that is happening. So that is the separation phase. And the last stage is redefinition phase. Sometimes these mentee and mentor can redefine their relationship and they will become friends. So that is redefinition of the relationship. These are the 4 phases of mentoring in most of the mentor-mentee relationships. So this is important. What are the different core elements of any mentoring? First, what is needed is mutual trust. Without trust, there can never be any mentor-mentee relationship that is happening or any mentoring that is happening. So first one is mutual trust. Second is mutual respect. The mentor and mentee should show mutual respect. Third important one is confidentiality. The mentor and mentee will be discussing many aspects, isn't it? So during the process of mentoring, the mentor may be telling about his childhood, her childhood, or some issues that the mentor faced during their time in the MBBS, or something the mentor will be sharing. Similarly, the mentee will be also sharing some problems.
So there should be confidentiality. Both of them cannot go around gossiping. That's one of the important aspect in mentoring. So confidentiality is very, very important. And it should be development focused. Just looking at attendance of the mentee, just looking at whether they have attended classes, just looking at internal assessment marks is just supervising. It is not mentoring. So any mentoring should be development focused. It should be focused on the various aspects of the mentee, and it is mentee centric. The focus is on the mentee. So there is a mentee centered approach here, not mentor centered approach. Just like how there is self-directed learning in teaching and learning, so here also it is a mentee centered approach. So we told before, mentoring is about many aspects, isn't it? The mentor can be a role model, can be a challenger, can be career counselor, developmental advisor, professional advisor, critical friend and facilitator. So many things the mentor has to play. It's not just teaching alone or not just supervising alone. There are many roles for the mentor to play. So if you have a mentor, what qualities would you like the mentor to have? What qualities you would want your mentor to have?
He should be knowledgeable. Fairly knowledgeable.
Mentor should be fairly knowledgeable. That's what they told me.
Mentor should be like Gautam sir.
You tell sir.
Approachable, man.
Yes, correct. Approachable. Mentor should be approachable.
Supportive and encouraging. Supporter. You should be an active listener, motivating. And building confidence.
Problem solver. So problem solver, motivator, advisor, supporter.
Point out if any mistake is done, correct me if I'm doing something wrong.
So criticism, constructive criticism the mentor should be able to give.
Caring like a mother, respectful like a father.
Caring like a mother and respectful like a father. So we already told most of these points, isn't it? So a good mentor, like someone said, should be active listener, should be respectful. What is the third one? Should be available. So when the mentee requires, the mentor should be available. Should be experienced, somebody told knowledgeable, should be experienced. Then should value diverse perspectives, should not be narrow-minded. Should be able to give constructive feedback. And should be able to, what is the last point? Sir told, Kishore sir had taken a class about networking, isn't it? So the mentor should be able to network and find resources for the mentee. If there is any courses or some other platform which will be useful for the mentee, and if the mentor gets to know about that, the mentor should inform the mentee about that. So it should help in networking and finding resources for the mentee to grow and prosper in his or her life. At the same time, a good mentee, again, mutual respect should be there, should be responsive, should be accountable. While it is important to know what a mentor should do, it is more important to know what a mentor should not do. Don't impose your agenda. It is solely mentee driven. This mentor-mentee relationship is mentee driven. You cannot make the mentee do your work. I think Dr. Shravanadipti also had told about this. So don't impose your agenda on them. Don't judge or label the mentee. Don't be judgmental. This already we told. Do not break confidentiality. Do not dominate the conversation. So someone told active listener. The mentor should be active listener. So most important thing is to listen. You cannot go on talking, isn't it? So don't dominate the conversation. Allow the mentee to speak. Don't give unrealistic promises. So here mostly we don't see that, but sometimes mentors, what they do, I'll get this done for you. I'll make sure that you do this, or some promises the mentor will give. So that is not allowed. Don't be unavailable, this already we told. Do not micromanage or overparent or involve too much into personal matters. Do not discourage or dismiss concerns. If they are telling about some problems, listen and later see what you can do, but don't shut them off. Do not do the mentee's work for them. You should tell them how to do. You should guide them, but you don't do their work. And do not cross boundaries with the mentee. So what are the challenges in mentoring? Can anybody tell any challenges? Patience, time, availability, lot of work, this is additional responsibility, isn't it? So some of the challenges we'll see. Unnatural expectations. Unnatural expectations is also a challenge. My mentor will do everything for me. I have my mentor, so I don't have to do anything. So that attitude is also not correct. So first, most important obstacle or challenge in mentoring is the lack of intention. It can be from the mentee side or from the mentor side. What to do mentoring? Why should I do? That kind of attitude. So find value in mentoring. Don't be apathetic about it. Other challenges, rightly pointed out, time is a very important challenge. We'll have to invest a lot of time into mentoring. Also incompatibility. Sometimes mentor and mentee may be totally incompatible, then it is a very challenging situation. If the mentee or the mentor breaches confidentiality, the trust is broken and there won't be any mentoring that will be happening after breach of confidentiality. Crossing the boundaries, personal issues, especially with the opposite gender, is not recommended. And finally, all students are not the same. So somebody told patience is important. Some students may take time to understand what you're talking. Some may be very quick in grasping things and how the mentee-mentor relationship should be taken forward. They'll know it. Some people will not know. So you'll have to take your time and little bit of patience. So regarding the breach of confidentiality, there are some situations where you can't keep quiet, isn't it? Some of the examples are, so whenever there is a threat to life, the mentee has told something and you feel there is a threat to life, whether the mentee's life or somebody else's life, whenever there is a threat to life, whenever there is a law-breaking situation, legal issues, ragging, and serious medical or psychological risk, if you notice any of these things, you will have to breach the confidentiality. Ideally, you will have to tell the mentee that I am going to report this and then tell. And when in doubt, seek help of the administration, the heads of the institute, so that you can come to a solution. This, like we told before, what do I get from being a mentor? So you may find that making a difference for others makes the biggest difference in you. Okay? But this is not the only thing. There are mentors also get something. So what all can they get if they do it properly? Self-satisfaction, enhanced leadership skills, newer perspectives. There are a lot of things that we can learn from the students also. Professional recognition and network expansion. When you try to do networking for yourself and for your mentees, you yourself will expand your network. So these are some things that mentors also get as a part of this mentoring. And how is teaching different from mentoring? A teacher will tell you to read a book, will tell you information, and it is his job is of educating, and they will follow a syllabus, whereas in mentoring, the mentor will, this analogy, so the mentor will read the book with you, provides opportunity to access information, and the job is to inspire students to educate themselves, and every time the mentor and mentee meets, there will be some learning that is happening. So these are some differences between how teaching and mentoring are different. Who are these people? Sachin and coach. Yeah, so coaching and mentoring is also different. So that is Ramakant Achrekar, Sachin's coach, and that is young Sachin, isn't it? So what does a coach do? How is coaching different from mentoring? Coaching is usually skill specific. There is when the coachee has to hone some skill, then he will seek a help of a coach. That's a coach and coachee. So what are the key objectives of the mentor-mentee program? We should remember these. To create an environment of mutual trust among the students and faculty, to encourage interaction and to reduce peer pressure, to help students manage personal issues, if any, without intruding too much, and to reduce stress and depression among the medicos. These are some of the key objectives of the mentor-mentee program, and studies have shown what students expect from the mentors. They expect honest feedback, responsiveness and reliability, networking opportunities, general career guidance, clinical aspects and research expertise, and willingness to discuss some difficult topics. So these are some of the things that student wanted. This was from one of the studies. What do medical students want from a mentor? That was done. And how to do it? So what does the CBME guidelines tell about mentoring? So the mentor-mentee program shall be carried out judiciously with the ratio of 1 mentor to 3 mentees. The mentors shall be selected from all the disciplines from the level of professor to assistant professor. Mentees will be allotted when? At the time of the foundation course in the first year, phase 1. And from phase 1 it is a longitudinal process. That is, the mentee shall remain connected with the mentors throughout their career till he or she completes internship. So till then, the same mentees the mentor is going to have. And each year what will happen? Each year new students will join in first year. So each year 3 new mentees will be getting added to the same mentor. So you will have, as a mentor, you will have 2 students from second year, 3 students from second year, 3 from first year, 3 from phase 3, and another 3 from phase 4. So what happens in between them? They'll have a healthy sibling-like environment. That is the expectation, hope. So instead of ragging, they'll have a healthy sibling-like environment. There will be some peer mentoring that's happening in between them also. So we'll give you handouts now. It is to, it's been given, no? So it's just for self-reflection. You can just see what is written there. It is to assess the skill as a mentor. You can give marks to yourselves, need not be shared. It's just for self-reflection.
Effectively with your mentees,
other mentors.
That's okay. We don't have that. This is actually from a study, just for self-reflection. So if there's any point, other mentors, maybe other mentors, if they can help
Same
in some
student, other mentors.
Yeah, if there is a need, we can coordinate. So studies have shown that students have learned many things from their mentor during this mentoring programs. So like provided counseling, guidance, problem solving attitude, approach towards exam and evaluation, time management, some of them learned from their mentors, approach towards subject, confidence to participate in extracurricular activities, character development, professional approach, motivation, discipline, work-life balance, so on and so forth. So concluding, each student is different. We should have a strong intention to do mentoring, build a relationship of trust, that is the heart of mentoring, not just support to mentees, but provide some surmountable challenges also, give them small challenges which they can do and cross, and respect boundaries. Thank you. Good afternoon, everyone. I am aware of the time, so I will not take more than 15 minutes maximum. So my topic today, it was a 45-minute session, so I have condensed it to 15 minutes. I will tell only the important points. Okay, so my session for today now is how to draft a schedule for a phase based on competencies. How many of you are aware of this? How many of you are doing this already? Yes? So most of us know. This side nobody don't know? Okay. So I'll just briefly summarize. Our objective for today's session is understanding the steps in drafting the timetable for one academic year. I'm afraid I cannot make it interactive like all my other sessions, so you'll have to bear it with me for some 10-15 minutes. What can you see here? There's a clock, then there's an alarm. So there are so many things going on, isn't it? But what is at the center of all this? There's a calendar and there's a lot of planning going on. Usually for any event, most of us go with a plan, isn't it? Same way in academics, we have to adopt to a plan, preferably a long-term one, so that at least 80% of the teaching program which is planned will go according to schedule, otherwise it goes haywire. I'll show you some more images of planning. This is another planning at a workplace. Something far more interesting you all can relate to. How many of you like to go on trips? All of us like to go on trips, including me. Do we have the time? We can make time if we want to go. Who does the planning? I like to go on trips in which I don't want to plan anything. Somebody else does all the planning, we go and enjoy. So planning is a big task. So here are a group of people who are planning an adventure. So now before going further into drafting a schedule and all that, see, each one of us works differently. You agree with me? Does each one of us have a different working style? Yeah. I'll show you some styles which I know. So maybe you can relate to that.
Who is the sprinter who works well under pressure? Please raise your hands. Anybody who can work, so Lokesh sir, Ramya ma'am. So, Dr. Afreen, that's all, Ravi sir. So very few people you can work under pressure. Kishore sir, I am one of them. I work best under pressure actually. The other type, somebody who gets easily distracted, but somehow gets everything done. Anybody here? Somebody who gets easily carried away by distractions? No? All of you are focused? Only while reading you get distracted, not while working. So all of us are focused? Okay. Then there is the third type, who is the planner, who likes structure, who likes everything which is planned ahead. How many of us? You work according to plans? Yes, this table? Nobody likes planning? So you're neither sprinter, nor drifter, nor planner. Then what is your style of working? In between all this. Thinker. Critic, ma'am. Critic. Here. Okay, there's one last thing. I think most of us agree with that. Multitasker. So sir has raised both hands. Even me. So multitasker, we try too many things. Now the question is, forget about what is the style of working. Ultimately, what is our goal? Get things done. Get the job done at the given time and moment. So which kind of person will you involve in making a schedule? So I'll just give you an example. Supposing a sprinter drafts a schedule. How will it be? Just tell. He's working under pressure. So say suppose submit the timetable on 10th of December. Too many mistakes? I don't agree. Okay, imagine we ask them for a final version to submit it on December 10th. Yes, most probably the previous day by midnight they will submit. Because they will wait until everything builds up. So much of pressure is there, and that is when they... Sir? Sorry? Yeah. ACME proposals you mean, okay. Yeah. So it is always better, supposing a person like this, you give them that work, what happens? There will be too many gaps, but he will think it's okay. We'll do it. Don't take tension, we'll do it, aram se we can do it. How about the planner? Perfect, very meticulous. But somehow these are the people often because they are too meticulous, no? They get carried away. There can be some mistakes. Can be? Easily failed also, yes, because you should have other options ready in case a situation arises. How about the last one? Too many things. They have too many expectations. They feel everything has to be done. Everything is important. So everything they try to pack into one given time frame. Okay. So, sorry? Some things will happen. That is the positive way to go about it. If everything happens, even better. Okay. So planners, they produce a neat structured timetable. Now I am relating this to our how to draft a timetable, because in every department we have all types of people. So it's up to you whom to allot and whose help to take when it is required. So planners produce a neat structured timetable, but it will be very rigid. No gap in between. Sprinters, they will leave empty blocks. I told you they work under pressure, they say it's okay, we will see, we'll take care of it. Drifters create a very inconsistent schedule. Multitaskers, they overload the timetable. They feel like everything is important and everything has to be done. Now let's come to teaching schedule. What is a teaching schedule? So it's all there, I don't want to go into the details of it. It's a schedule of events that organizes teaching activities throughout the day, a week, a month, and then throughout the year. So it's very, very important to have a yearly timetable for us, because it shows what exactly has to be done at a given particular time, at a given moment. So why do we require a teaching schedule? Planning, it tells what the learner has to learn, what the teacher has to teach. So that specificity is there. It directs the attention of the learner one thing at a time. Yeah. So what are the steps in drafting a timetable? Supposing say MBBS curriculum in your respective phases, if you are given the task of drafting a timetable for 1 year, what all things you will think of? Duration, very good, duration of the course. Say 13 months for phase 1, I'll assume. Let's take example of phase 1, so 13 months duration. Then? Yes, allotment of time, number of hours allotted for. Yeah, so first we will look at number of teaching hours, overall, total, including lectures, small group teaching, including all the different types of teaching methodology. We have to, who will give that? It's there in the curricular module. The number of hours which has to be taught for each subject across a phase is clearly mentioned in the curricular volume by NMC. Next, what you will do? Topic. Shortlist the topics. For which topic? All of you have presented so beautifully the competency and the preferred teaching learning method. So plan for each topic what exactly is the teaching learning method which has to be adopted. Next. Very good. What is alignment? What do you mean by alignment? No, okay, forget about medical education. In literal terms, what do you mean by alignment? Aligning means what? Matching. Yes. At the same level. Isn't it? So in medical education, alignment, supposing I'm from phase 1, so I think I'll use the example of phase 1. I'll give you an example of alignment. Say if anatomy is teaching thorax, we teach cardiovascular system or respiratory system. Obviously biochemistry we cannot align on many topics, but at least whatever can be done, we try to align. Supposing they are teaching head and neck, we will also try to teach something related to central nervous system. So that there is no redundancy, there is no repetition of topics, and the student can relate better. So just imagine when they are dissecting the lungs, we teach about respiratory system. So the understanding is much better. All it takes is a very small effort from our side. We just have to plan everything in advance. All the 3 departments have to sit and plan this together. Obviously, sometimes somebody will tell you, I don't want to teach this now. Small disagreements will be there, but we have to overcome all that and come to a common consensus, and we can implement it. Another thing is integration. What is integration again? Yes, involving different departments. Again, we have horizontal integration and vertical integration. So I'll not go into the details of all this. Basically, whatever you have told now, let me just quickly show you. So this is say for phase 1, these are all the things which we have to do in phase 1. So there are the basic subjects, a foundation course of 80 hours. So it was planned for a week. Introduction to community medicine, early clinical exposure, family adoption program, EdCom module. So these are all the things which has to be incorporated into the timetable for first MBBS students. So what is the next step? We said we have to know how many teaching hours. So the NMC curricular module gives number of teaching hours very nicely split into lectures, small group teaching, the number is given, so everything is there. So we count this, and what is the next step? You count the time available for us. Supposing say the course is starting on 15 September 2025, 13 months will be, sorry, it is 15th October 2026, pardon me. And time available approximately will be 42 weeks. From that time available, we will have to deduct the time which will be taken for exams, vacation, internal assessment, public holidays. So you minus all those days, and the remaining days you calculate multiply them by how many hours per day? Mostly 7 hours per day, 7 hours of teaching per day. So you multiply that, overall you get a number of 1638 hours of teaching. Now this has to be properly planned. So once you calculate the number of teaching hours, first you make a master timetable. We just have to mention the name of the department and whether it will be theory or practical. That's all. Make a master timetable for a week. For example, say Monday. In phase 1, Monday 8 to 9 anatomy, 9 to 10 biochemistry, 10 to 12 will be dissection, 2 to 4 will be practicals. So all phase wise we all have a weekly schedule. It is crafted in such a way that if you add up all the weeks, the number of hours should match, which is given in the NMC curriculum. So obviously if you take a first year timetable, everywhere you will see anatomy, because they have like 650 hours of teaching. Followed by that we will see physiology, biochemistry will have the least number of classes. These are all the things which has to be incorporated in a teaching schedule. Didactic lecture, practicals, if there is early clinical exposure, we'll have to mention that. Mention EdCom, SDL, SGT, simulations, sports, all these things have to be there in the timetable. So first we make a master timetable for a week and then copy it, copy paste for 42 weeks, and then you can start inserting the topics and the name of the teacher who is going to take that day's class. I'll show you an example which is done. Can you see? Is it visible? How to zoom this? Okay, call. So this is the timetable, a weekly timetable. Okay, I'll just read out. So 8 to 9 class biochemistry. So you can see the competency is mentioned and the name of the So you can see the competency which is mentioned there. And when dissection hours, the number of the competency number is mentioned. And then physiology, you have, there is pre-practicals, and then there is practical for all the 3 departments from 2 to 4. So each department, whatever they are teaching in their particular departments will be mentioned. So like this, we make it for a week, and then that you copy paste and make it for all the, throughout the year. So in between, whenever there is an integration or whenever there is alignment, so if somebody looks at this timetable, this I've just taken randomly some month. So if you see, in first year, I told you about alignment, isn't it? 80% of our topics are aligned, and it worked beautifully last year. So this year we made it with even, we were even more meticulous when we were making it, and it was easier also. So once you make it, I think it's very easy. At least 80% if we are able to stick to it. But to achieve 80%, first we have to draft a schedule. I think that is very important. Okay, so this is about alignment which I was talking about, alignment and integration. Okay. Okay. Then the next step will be to get it verified from all the concerned HODs. Once that is done, it is available for implementation. So that's my session. I just want 1 second. You have some sheets of paper with you, no? Just now some sheets were given. Some A4 sheets you have. All of you has got some paper. So turn that back. Please rate your BCME experience as an emoji. Let us end it on a fun note. Can't see. Or you can enact. Yes, Dr. Ashwin, you can enact the emoji. It will be more fun. Each one of you. Smiley, okay. Shri Priya smiley. Savita heart. Smile. A neutral smile, no? Okay, what do you call that? I don't know who's good at interpreting the smileys. I know what it means, but I can't tell what it is. 2 hearts in the eyes and a smiley, okay? Okay, with teeth, no. Thank you. Yes, quickly, the quicker it gets over, the quicker we can wind up. Smiley. Blooming. Happy. Okay, super also. Any high fives? Okay, you learnt a lot, you're proud. Adipoli. Super. Here. Okay, great. Abra is smiling, finally. Okay. She's also very happy. Oh, you're Rashmika style. Okay. Smiley, smiley, smiley. What is this, sir? Sleeping, sir? Sleeping, huh? What is yours, Gautam? What is that? What do you mean? Hey, I want to show this.
This is poker.
See, he's having a poker face. Always wants to stand out, isn't he? Thumbs up, okay. Nice drawing. Neutral, huh? Poker face again. Isn't it? Just like Gautam's. Okay. Crying. Madam. No, it's not written happy. Allah Karthik. The romantic person is crying. No. I don't know. Everything mixed, huh? Mixed emotions. ఏంటి సార్ ఇది? Oh, okay. Smiley. Very nice. Okay. Happy? No, it's not mentioned. I take it as sad. There's no smile. Okay. Happy tears, sir. Sorry. So Karthik is so happy that he's crying. We respect autonomy, so we'll take it. Extra certificate. I told him that time also 2 certificates he'll get. Happy tears. Ippadiya. No. Ayyoda, so much is there to learn. Ada. Thank you everyone for your active participation. We really enjoyed the session. Please fill up the feedback forms. Thank you.
Okay, we are distributing. Thank you, Dr. Ramya, for that very brief but very mandated feedback. So kindly fill it carefully. Don't leave any columns unanswered. Okay? And because we have to submit it to the nodal center, I want you to carefully fill it. Don't put any emoji on this, however you are tempted to, but please fill it with words. So actually there are 2 physical forms and 1 Google form to fill. Post-test is also there. 2 Google forms, 2 physical forms. Once you have done that, we'll ask Dr. Abrar to give the repertoire report briefly, and then we'll go to the valedictory. Okay? So please do it in that order.
Good evening everyone. I am Muhammad Abrar, Assistant Professor in Pharmacology. So I am going to summarize what happened today for the third day. So today's session started with writing a lesson plan by Dr. Sachidananda Adiga sir, Professor and Head of Pharmacology. So first sir has described what is the lesson plan is and the advantages and disadvantages of having a lesson plan and how to prepare a lesson plan. So preparing lesson plan from a broader competency, split into the smaller competencies and make a lesson plan for each topic individually. And then sir has described various types of lesson plans and then what are the elements that are there in the lesson plans. And finally, a lesson plan should be relevant, clear, flexible and feasible and should not be too exhaustive and too detailed. Then we continue with the second session, which is on assessment and skills by Dr. Ramya ma'am, Professor and Head of Physiology. So ma'am has described the purpose of the assessment and various methods of skill assessment like OSCE, OSPI, OSLR, Mini CEX, DOPS. Then we had a small tea and snack. And then there was an activity of preparing OSCE station checklist. And then Dr. Ramya Ramakrishnan ma'am, Associate Dean Professor of General Surgery, ma'am has presented Mini CEX where it was demonstrated by using role play. And then DOPS was also demonstrated using a video. And then we have a third session where it was taken by Dr. Chittoor sir on academic growth, where sir has clearly described the history of the medical education in India and various NMC guidelines and what are the avenues of academic growth in medical education, which sir has described 4 domains. And then what are the roles of MEU and what are the opportunities that we have further like ACME and FIMER. And sir has briefly described about the importance of networking and advantages and the limitations of social networking. And sir has ended the topic with tips of networking. And then we dispersed for the lunch. And then after lunch we had fourth session, where each group has participated in making objectives from competencies and choosing the right teaching learning methods and assessment for the competency given and then presented, which is facilitated by Dr. Sivachandra Raju sir and Dr. Chittoor sir and lively engaged by the other faculty also. And then the fifth session was by Dr. Jyoti ma'am, Associate Professor Pathology on mentoring. Ma'am has described various aspects of mentoring, why mentoring is necessary and various types of mentoring. Then stages of mentoring. What are the challenges we encounter while mentoring and differences between teacher, coach and mentoring. And then we have the session was ended with a self-reflection on mentoring. And then finally, the last session was taken by Dr. Ramya ma'am, Professor and Head of Physiology, drafting schedules of a phase based on competencies, where importance of having a plan to produce a neat and structured timetable, and then what actually is explain of having a teaching schedule, and why do we require a teaching schedule. And Madam has clearly described various steps in drafting a timetable. So by this we have concluded all the sessions, and then we have given proper feedback and post-test. Thank you everyone for conducting the BCME.
Thank you, Dr. Abrar, for that repertoire report. Very well done. Thank you. So we come to the end of this 3-day basic course in medical education. I have enjoyed it very much. I don't know about you, but I was very amazed and very touched by the emojis that all of you had displayed just now. Thank you very much for the very, very interactive participation of all groups, all participants. I know we have all your busy schedules, and despite that you have shown so much of interest in this. And now I would invite actual feedback on the mic from 2 participants. Anybody can come, just tell briefly about the feedback. I know we have already asked so many forms, but it will be nice to hear from you. Volunteers. Okay, Dr. Subramanian.
I attended some FDPs here in this hospital, in this college. So I expected what can I attend more FDPs. So I think this is the one that almost all the FDPs, if I group, it will be the, I think, BCME. I think it was very engaging, and all the sessions are very good. Maybe some lectures are boring. Otherwise, in between they are engaging. They all the facilitators, everyone try to engage in all the activities. Maybe even who have not listened in their UG or PG have participated here. Or yeah. Thank you.
Thank you, Dr. Subramanian, for your very honest feedback. Thank you, we appreciate it. We want one more volunteer. Yes, please.
Introduce yourself.
I am Dr. B. Sahul, Assistant Professor from the Department of Pediatrics. First of all, I want to thank MUE members. Thank you so much, sir. You have shown great efforts in teaching BCME and various new learning and teaching methods. Thank you so much. Actually, I joined here 1 year back, so I got to learn so many new things, and I got to know how to prepare teaching schedule, timetable, everything I got to know. I am from the bottom of my heart. Thank you so much, sir. And sincere thanks to our Dean Madam. Madam actively participating continuously throughout the day with our, it's great. It's super, Madam. At this age, your encouragement and your support. Sir. No, Madam is continuously actively engaging and supporting each other. Thank you so much, Madam. And also I want to thank all our partners in the group 1 and also all other colleagues for actively participating. Thank you so much.
Thank you, that was very sweet of you and very honest feedback, and very honest about my age also. That's nice. That's very engaging and very nice to hear heartfelt comments. That's what we want, and that's what we want the learning also to be. And so thank you very much for your feedback, and both happen to be pediatricians, so they are honest and from the heart they speak. I know that, so thank you very much. Now I request our respectful observer from the NMC Nodal Center CMC Vellore, Professor Ramya, who is Professor and HOD of General Medicine, to please share her thoughts on the BCME for the last 3 days.
I think first you should thank both the volunteers, otherwise we would have waited till 6 o'clock if nobody got up like. So please thank them first. I just want to thank all of you for the hospitality you have shown in the last 2 days. I mean, the warmth and how you, to interact with you was very, very nice. Thank you, all of you.
And also, I think you have an excellent MEU team. And I was telling ma'am's enthusiasm doesn't wane. Morning 8 o'clock, same enthusiasm, evening also 5 o'clock, same enthusiasm. So I think she's a very inspiring person to have as a team leader for the MEU. And all the young stars, Ramya, Jyoti, Dr. Shravanadipti, and also Dr. Kishore, Dr. Sachidananda Adiga. I think you have a lot of great teachers here, and they have put in so much effort into the sessions. I agree the theory behind medical education is very boring. I completely agree with you on that. So, but the thing is, it has to be literally stuffed into your throat, like how we stuff into our medical students, how we teach them. So, I think there are a lot of interesting sessions, developing SLOs, self-directed learning, small, large group teaching and all. But I really enjoyed the hands-on sessions you were doing and the effort which was put in by your faculty, because they were coming, standing with you and helping you write up the flip charts. So that is what you should carry with you, what you have learned by doing hands-on, and you can develop it, and I hope you develop it through all the coming years and keep working on it. I'm sure you're all excellent teachers, but this is just to sharpen your ability of being a teacher. So I hope you enjoyed this workshop and all the efforts which our MEU team has put into it. All the very best, and I would still encourage you to do advanced medical education course, do your PhDs. I hear there are 2 upcoming smart PhD students in the department of MEU, so there's a PhD opportunity also for you. Please do research, because I'm telling you, the students cannot go anywhere. For 5 years they are under you only. So best place to do research is medical education. So I encourage you to do medical education, and thanks, and also once again all the very best. I think you're very bright young teachers and you will do very well in your life.
Thank you very much, ma'am, for your very, very kind words. We really appreciate your patience and presence the last 3 days, and encouraging us all to do what we are supposed to do. So thank you very much. Now I'll request Dr. Sachidananda Adiga and Dr. Kishore to felicitate our observer ma'am. I'll hand it over. I will give it to you. You give. I'll request Dr. Kishore to hand over another small gift. Now we'll go to the much awaited part. You will receive all your certificates from ma'am and other MEU MCC members here. So we will just call out your names and please be ready to come and receive it. Thank you.
I don't need a mic. I don't need a mic.
No, you can't give, no?
Thank you, ma'am. Now we have the celebration doesn't stop here. We have a small cake cutting ceremony. Today is Dr. Yamini's birthday, so we are going to wish her happy birthday, and please Yamini, come and cut the cake.
Last year's BCME, last day was again one birthday. Last year BCME happened on 3rd, 4th and 5th of December 2024. 5th was Dr. Govardhan's birthday, and luckily today also the same thing happened like Dr. Yamini's birthday. All of you can come forward.
Happy birthday to dear Yamini. Happy birthday